or make you a co-host. So the outsiders cannot come and share our screen. One part of the time, only host. Good. Now I will make you co-host. Make co-host. Make co-host. Then spotlight for everyone. Good morning, everybody. Welcome to the last but one lesson of the Indian Academy of Orthopedic Surgeons online course on biological methods in orthopedics. This course had an overwhelming response so far and has been co-conducted by Dr. Diwaker and myself. As we come towards the end, we have decided to keep the invitations open because before the previous 16 lessons, only participants who had paid the fees and registered for the course were with us. Now, the last two lessons, this one and the next lesson on the coming Sunday, which will be my lesson on genesis of biological methods. These two, we have opened it to general public to have an idea and encourage the next batch of candidates to join. Today's talk by Diwaker will be on painkillers, meaning anti-inflammatory drugs, non-steroidal anti-inflammatory drugs. These are basically, one minute, let me get the view proper. Gallery, yes. So these are basically both blessing and curse. I will ask Dr. Diwaker to start his talk by first giving some slight introduction, after which he will share his screen and show us his slides. Thank you, Dr. Diwaker. Please.
Yeah, good morning to everyone. So by this lesson, I'll teach you some basic aspect of the orthopedics, which are often missed. And one more lecture I would like to add, that how to judiciously use antibiotics and properly. So this talk was initially prepared in 1976 when I was given a topic to speak on anti-inflammatory drugs. Till that time, the word NSAID was not introduced. And I was taught that all anti-inflammatory drugs, they stimulate pituitary adrenal axis through which anti-inflammatory action takes place. But when later it was realized that action is due to something very new, that is Cyclooxygenase or some other method. So they were given a separate group known as non-steroidal. Previously, all thought to be steroidal anti-inflammatory drugs, or steroids were thought to be the only inflammatory drug. So when later it was realized they are something different, so the name separately has been given. Just like in 1916, every joint pain was thought to be due to deposition of uric acid, and it was told as gout. Uric acid was not known, but gout was known. So gout was thought to be the only cause of the joint pain. But in 16th century, people have realized that there are other pains which are not gout also. So they have divided all the joint pains into gouts and non-gouts. And non-gout later divided into seropositive and seronegative. So what we are taught now, seropositive arthritis and seronegative arthritis. Now we have 152 total arthritis. So now really I start the basic allotted lesson today, that is anti-inflammatory drugs. So when in 1976, I was reading through rheumatology books in my library because that was the only source at that time. So almost every book that slammed anti-inflammatory drugs, that they are not so good and don't use it left and right. And still, many people, many means 99% or more, they are still using anti-inflammatory as a safe drug. But they are totally unsafe like quinolones we use. We should know the basic physiology, pathology, pharmacology, and pharmacodynamics, so that we should use these drugs judiciously and we always remain safe. So now let's start. It's a open treasure and hidden menace. You must have all seen. Are you hearing me clearly?
Yes, Dr. Diwakar, you are very, very clear. I have muted all other mics so that
Okay.
you don't get any disturbance.
So you
Put this play in full screen mode so the slides will be slightly bigger. You can play slides.
okay? I'm playing slides. So now where is play button?
You
Play is
up. Ah, no. Yes, no. Go back. Go back.
okay.
Yes, go back. Now there should be slideshow. No, slideshow. Yes. Start slideshow. From beginning, extreme left. From beginning, slideshow and extreme left, first column. Ah, good, from beginning, yes.
From beginning. Okay.
Yes, good, correct.
So now all of you must have seen the cardinal signs of inflammation. Celsius, who has advised 5 cardinal signs. The one, heat, redness, swelling and pain, and this is known as dolor, rubor, Keller, and tumor. And Virchow later added loss of function, that is functiolesia. So this all people knew 2,500 years back. They knew that inflammation was something. What it was, we came to know right in 1980s. There was a word, hypnos. It's a personification of sleep. There is sleeping. He is son of Nyx and Erebus and twin brother of Thanatos. Thanatos, you know, that is death. Nyx, primordial goddess of personification of night, and Selene, Titaness, goddess and personification of moon. Because selenium was first found on the moon, so that's why it is named as selenium, because the selene is moon. So people used to think that Morpheus is the goddess of sleep, and she is giving a person sleep. So hence when morphine was discovered, it was named morphine, because they thought that after giving morphine, you go into the arms of the Morpheus. It was first known as god of dreams. He shaped and framed the dreams, through which he could appear in mortals in any form. People thought that Morpheus can come into the dreams. The stellate made Morpheus a messenger of the gods, able to communicate divine messages by sleeping mortals. Because gods don't want to come directly into the public, so they came through sleeps, as they thought. And morphine was first isolated between 1803 and 1805 by German pharmacist Friedrich Schättler. It was discovered in a raw form, but opium was known since ages. I think more than 10,000 years people knew what opium is. But he separated the substance morphine just 200 years back, and Merck began marketing commercially in 1827. So Morpheus slept in a cave full of poppy seeds. This is what mythology says, while shaping mortal dreams. So he had a lot of work there to shaping dreams of the millions of people. This could be the reason why opium-based medication for severe pain is known as morphine, as I explained already. And poppies have also been used to treat insomnia due to their hypnotic properties. Then Friedrich William Adam Sertruller was a German pharmacist, pioneer of alkaloid chemistry, best known for the discovery of morphine in 1804. He was first to isolate morphine from opium. He called isolated alkaloid morphium after the Greek god of the dreams. Opiates originally derived from opium poppy have been used for thousands of years for both recreational and medicinal purpose. The most active substance in opium is morphine, named after Morpheus, the Greek god of dreams. Morphine is a very powerful painkiller, but it is also very addictive. One very interesting incident I tell you, that was about 35 years back. My friend's wife, she called me at the middle of night about 2 o'clock. She was having severe chest pain. And one of my friend already came and he has given the recent drug arrived that time, that was diclofenac injection. And the patient was not healing. Then I had few ampoules of the morphine in my bag and I have given her 1 injection of morphine. After that, she said, there's no pain relief. Then I have given another injection of morphine IV and still there was no pain relief. Then I was wondering how much is this such pain which is not relieved by the morphine. And I knew that morphine can kill every sort of pain. So I immediately thought, oh, she's having some psychological pain and say panic attack. And the alprazolam was given and she was relieved of pain in slept. So now that time I discovered that panic attacks, they mimic severe pains of backache, chest pain or anything. And if not relieved by opium, this is a simple test I have derived afterwards. And give opium, no pain relief, that means patient doesn't have a real pain. If it is a real somatic pain, it has to be subsided by the morphine. And since thereafter, she is ever happy that she takes alprazolam whenever she gets chest and back pain. The history of the NSAID or analgesic drugs in the Middle Ages, spongia somnifera. Somni is sleep. Hypnosis is also sleep. Dreams, somni is sleep. Sponge of the sleep, soporific sponge, was added as an application form in 16th century. Parselius increases the analgesic effect by introduction of tincture of opium, which have been used in various forms even 5 centuries later. Alcohol property is analgesic known since ages. Willow bark, Salix alba. What is willow bark? Strips of the bark used to make baskets previously. So they have seen willow bark, Salix alba used in centuries, hydrolyzed to make salicylic acid and sodium salicylate in 1875. Acetyl salicylic acid, phenacetin, and antipyrine began in 1899. Phenylbutazone, it was just discovered by chance when they have found that antipyrine injection is more effective than antipyrine tablet. And the cause was not in injectable form, cause was the solvent of antipyrine, which was more active as analgesic, later discovered as phenylbutazone. Then 1960s the time the NSAIDs introduced. Discovery of the first NSAID, indomethacin by Merck. Indomethacin is the first NSAID discovered. So indomethacin had some very good property and it was much more, about 20 times more active than the previous drug available, that was aspirin or other aspirin analog. So since then, I know my family has purchased this drug in 1963 for 11 rupees per capsule. That time it was almost equivalent to the 2-3 grams of gold. So it was taken as a dramatic drug, more effective than the previously introduced aspirin. And later on, this drug used as a comparator drug. You compare every new introduced drug with indomethacin. So the habit of comparing indomethacin made this drug as a benchmark drug. It is not a very good drug. It is a benchmark drug in initial times. People used to compare every drug with this. And still now many orthopedicians think that this is the best drug available. Everyone is giving indomethacin. This is a bad drug. gives headaches. Headache is the most unwanted side effect of this drug. Almost, I think, 50% people complain of headache. Headache, vertigo, acidity, all side effects are there. But only good thing with this drug is it is a very, very powerful antibiotic and used in cancers. This is the only indication I feel at this time. It is not a good drug for anything. It was only a comparator drug initially and thought to be a good drug, better than the aspirin only. And soon a whole range of NSAID followed, ibuprofen, diclofenac, and ketorolac, etc. Prostaglandins were discovered in 1930. Wolf von Euler, he found that seminal fluid of the seminal vesicles from the most animals, including man, contain a substance which causes contraction of the smooth muscle of the uterus. He named the substance prostaglandins since they were originally thought to be secreted by prostate gland. And one very interesting thing, when I was in gynecology, it was I think in 1977, in gynecology posting, my teacher, she has told me on an interesting thing, that any lady who is not in labor or not in labor pain, if given semen to eat, she develops labor pains. And she jokingly told, ladies say, "Tumhi ne dard diya hai, tumhi dawa dena." You have given him pain and you have given the medicine to get it out. So semen can be used as uterine antagonist. In 1795, Rev. Edward Stone described antipyretic properties of the willow. And in 1982, at least about 100 years later, Nobel Prize for the medicine for research in mechanism of action of NSAIDs has been given to John Jain. Bergstrom, Samuelson, and Bain were able to show that prostaglandins are involved in diverse range of biochemical function and process. If you go through pharmacology books, you will find more than 100 indication and more than 100 contraindication of aspirin and other drugs. And same with the steroid also. So for this reason, their research opened up a new arena of the medical research and pharmaceutical application. The research has significant implication in several critical areas, particularly in thrombosis, inflammation, and allergy. This is the beginning of NSAID. The word came used in 1963, although in India, we were introduced in 1840. When it was realized that anti-inflammatory action is not due to action on hypothalamic adrenal axis, though I was taught this in 1975 in textbook, that axis is responsible for anti-inflammation though. In 1930, human semen detected substance gave uterine contraction given name prostaglandin. In 1970, prostaglandin synthesis inhibition was taken as action of NSAIDs. Thromboxane, prostacyclin, leukotrienes, importance is well known by then as anti-inflammatory. Thromboxane, you know, thrombo is thrombosis. It is secreted from the platelet. Then combinational risks. This is something very important I have to teach you all. That adding two NSAID, they work on same receptor and they compete for each other. And individual action is much less. Their combination is very well compared. If you try to mix in milk or tea some form of aspartame or no sugar or saccharin, and if you try to add some more sugar to make it more sweetened, it will not. You need same amount of sugar which you need to sweeten, like 2 teaspoonful, and same amount of saccharin. If you need 2 tablets of saccharin, if you add 1 saccharin and 1 teaspoon of sugar, it will be still not sweet. It will be sweet when you add equal amount of these 2 saccharin and sugar. But in NSAID combination, it is even opposite because they compete for the same site on the same receptor. So 2 NSAID, they pose half of their effect. and a half analgesic effect is seen, and the toxic effect they combine because toxic effect don't use same receptor. So combination resistance COX-2 inhibitor is taken, it reduces the NSAID, prescription over the counter should not be taken at the same time. The term non-steroidal distinguishes these drugs from steroids, which while having similar icosanoid depressing anti-inflammatory action and have a broad range of other effects. First used in 1960, I told you already. The term serves to distance these medications from steroids, which were particularly stigmatized at the time due to the connotations with anabolic steroid abuse. This is something, this chart you should get it printed and keep with you, because this is not known to the teachings nowadays, because they teach in very short. Though I were taught all these things. At present time, there are 9 chemical groupings of the NSAIDs. The salicylic acid derivative, it is aspirin and sulfasalazine. Sulfasalazine, you know, it is used in ankylosing spondylitis. It is used in rheumatoid arthritis and other inflammatory disorders linked with the bone disorders like ulcerative colitis. It is sulfasalazine is a aspirin derivative. Then para-aminophenol derivatives are acetaminophen, that is paracetamol we know. Indole and indole acetate derivatives. These are 3 drugs, indomethacin, sulindac, and etododac. The sulindac I have read at that time, but still not came in India. It is a safer variant of the indomethacin. And etododac we are still using as a very, very safe drug, as etododac is a uricosuric drug. So this drug is particularly effective and useful in gout. And heteroaryl acetic acids, they are tolmetin, diclofenac, and ketorolac. Ketorolac is an unsafe drug used for only short-term use. Then aryl propionic acids, these are very, very common drugs. These are propionic acid derivatives. The common name for these are propionic acid derivatives. These are ibuprofen, the first one, naproxen, flurbiprofen, etoprofen, phenoprofen, oxaprozin. And recently one more drug added into the amyl propionic drugs that I'll tell you later. Arachidone, anthranilic acid derivatives are phenamides. Mefenamic acid, flufenamic acid, clofenamic acid. Although all names I have not written here. But mefenamic acid and flufenamic acid has come to India, out of which mefenamic acid survives. But this mefenamic acid is very, very powerful gastrotoxic. So use is very much limited. Rather not for the ortho patient. Mefenamic acid drug is for the gastroenterology and uterine services. And enolic acid derivatives are oxychems. This oxychem class, these are all sulfonamides. These are all sulfonamides. So remember, anyone who is having sulfonamide allergy, you should not give them oxychems until you have done sensitivity test or a small drug trial. Oxychems, paroxychems, kinoxychems, and pyrazolindinone, flambridazole. This is another book. I don't know how I have written here. Enolic acid is only oxychems. Might be pyrazolindinone have some relation with this. These are enolic acid derivatives are very, very long acting. Long acting means half a week to 1 to 2 weeks. Very, very long half-life. Then alkanones are nabimetone. This is a very good drug I like because this is non-acidic. This drug is non-acidic and this drug is safe in kidney. Then diaryl heterocycles, COX-2 inhibitors, rofecoxib, celecoxib, valdecoxib, parecoxib. These drugs came with a bang. At that time, it was thought that these are having less side effects, but they are found to be very, very cardiotoxic. And out of which, etoricoxib, the most toxic of all these drugs, is still prevailing in India. I don't know how the most toxic one prevailing and less toxic one, they vanished. depression hypothesis. The cytokine hypothesis of depression suggests that SSRI antidepressants increase brain levels of certain cytokines, which in turn increase levels of P11, the effect of which produces behavioral antidepressant responses. Each step in this pathway can be antagonized by NSAID co-administration. You see here, any antidepressant which increase cytokine, increase P11, increase behavioral, NSAID block here. So NSAID as anti-antidepressant, that means they work as anxiolytic. And this anxiolytic function was very useful in corona times. Many of my friends admitted in COVID wards, they were having high rise of CRP, and because of alone and the fear, they were too much anxious. So I have selected a single drug for them, given them NSAID, and they were relieved both in anxiety as well as with the cytokine storm. So I prevented many of the severe complications of the corona by knowing this hypothesis that NSAID, they work here and they work in severe anxiety in corona. Because morning and evening, my friend used to call me 14, 15 times that now what can I do? I have so much of pulse, I have so much of proximity, what I should do. So now I read this and I told them take this in single dose of NSAID used to relieve their anxiety. So this is something interesting to be known. Then again, coming back to the aspirin, barking up the right tree. In England, mid-1700s, a clergyman and university fellow studies the healing property of willow bark in search for an alternative to the cinchona bark treating for the malarial fever. Initially, they were thought to be relieved fever, malarial fever, but they were not relieving malaria, they were relieving fever only. The clergyman, Reverend Edward Stone, was the first author to demonstrate the effectiveness of willow bark as antipyretic with scientific rigor. Discovered as a bitter fever reducer, because previous bitter used to relieve malaria was quinine. So they thought another bitter, and someone might have tried Karela also. Salix alba, willow bark, hydrolyzed to salicylic acid in 1875, earlier told, and Bayer chemically modified this related molecule to salicylic acid, which were eventually named aspirin. The company patented name in 1899. It was an English cleric, Reverend, just I have told again, who rediscovered willow. In around 1757, Stone chewed on white willow bark out of curiosity and was struck by how bitter it was. He wondered whether it could be used medicinally, like bitter cinchona bark, where malaria drug quinine comes from. Stone gathered and dried around half kilogram of willow bark, then ground it into powder before taking small doses every 4 hours to reduce the fever. Drying the bark would have concentrated the salicin, making its effect stronger. When the powder seemed to relieve his fever, Stone tried it on his community, where community means the clergy, when they were sick. In 1763, he wrote to the Royal Society, reporting that it works in malaria. Other drugs, nefopam, a monoamine reuptake inhibitor and calcium sodium channel modulator, is also approved for the treatment of moderate to severe pain in some countries. This is one of the good drugs. And another good drug is flupirtine. It is centrally acting potassium channel blocker with a weak NDMA antagonist properties. NDMA, you know, they modulate pain in brain and spinal cord. It is used in Europe for moderate to strong pain, as well as in migraine treating muscle relaxation property. It has significant anticholinergic properties and believed to be devoid of any activity on dopamine, serotonin, and stuff. So this is not actually NSAID. Flupirtine is sort of opioid drug, and this is very commonly available nowadays. But there is a warning with this: use this drug for less than 10 days only. And this is something very good like other drug which produce nausea. This does not produce nausea because it is devoid of the anticholinergic properties. And this doesn't work on histamine receptor as well. So, however, tolerance may develop in some cases. Then, ziconotide, a blocker of potent anti-voltage gated calcium channels administered intrathecally for the relief of severe, usually cancer-related pain. Because we are not concerned with the pain medicine, but pain medicine people might have been using it intrathecally for the severe, non-treatable cancers. Then these two rules I have made about 2-3 years back. Rule 4, that means many years old. Just a minute, please. I have to answer one person. Akash, थोड़ी देर बाद बात करना, अभी हमारी क्लास चल रही है. This is another corona person calling me. So this was orthopedic rule 4. I have made about 3-4 years back. Never combine two NSAIDs. Net effect is lesser than either given alone, and side effects they multiply. Then later on, ortho rule 27. Do not allow NSAID introduced TB reactivation seen in post-operative orthopedic cases. Ibuprofen and indomethacin are most notorious. Why? Inflammation keeps dormant bacilli of the tuberculosis in place or in check. They do not allow them to multiply. The moment you reduce inflammation, the barrier around the tubercular bacilli is gone, and the dormant lying bacteria they reactivate and multiply. Particularly after post-operative nailing fever, if you see pus drainage is not stopping, always you try anti-tubercular drug and it works. And many old orthopedicians experience that every post-operative inflammation not respond to anything, they start using anti-tubercular drugs. And one of the orthopedic surgeon in Jhansi, Dr. Rakesh Tripathi, I have seen, he is using rifampicillin, all post-operative drug along with the antibiotics. So he must have seen that reactivation is quite common. And this ibuprofen and indomethacin, it is described in literature. It is not, I have made my own conclusion. This is described that ibuprofen is notorious for reactivating tuberculosis in the body. And another drug we are using, not as analgesic, gabapentin metabolized to pregabalin was superior for neuropathic pains to pregabalin and should be commenced before the pregabalin to permit crossover medicines. So you gabapentin first, then pregabalin. Then ortho rule 37 I made in pain medicine. This is a very good chart. You can write it down over diary. What pain medicine we should choose? If you have to treat bone pain, use NSAID. Muscle pain, use only relaxants. I use only relaxants for muscle pain and back. Nerve pain, use steroid. You give one injection of pharmacological, it is the root pain, it will be relieved. And you can ask all the spinal surgeons and neurosurgeons. They are using heavy dose of steroid to subside nerve pains. If it is a compression, use anti-epileptic therapy. You must have seen the use of anti-epileptic drugs here. And if there is a wound, don't use any of these. Use local analysis. The NSAID treatment paradox. NSAID can reduce inflammation, which may reduce excessive muscle degeneration. It is true that early use in trauma, it is beneficial to the muscles and tendons. So this is good thing about them. And what bad thing about them? NSAID reduce availability of the growth factors, cytokines, prostaglandins. These have separate function in the body. This is physiological thing that you need cytokines, you need prostaglandin. You need prostaglandin E2 for the mouth and stomach epithelial regeneration and mucosal regeneration. You need prostaglandin for the maintenance of kidney and blood flow, renal blood flow. If you inhibit renal blood flow and the mucosal repair, you are going to get mouth ulcer and stomach ulcer. So that's why this is the bad part, and that is the good part, that you prevent damage and you create damage. This is the bad part. And we have to balance these two. This is judicious use for how long to use, when to use, and how to watch the side effects so that you can change the NSAID earlier or you can totally altogether change the medicine. Children should tolerate NSAID better. So whatever said in pediatric fracture healing, let them have NSAIDs. Routine pediatric fracture healing is not impeded by non-steroidal antibiotics. I mean to say, fracture healing can be given NSAID, but generally pediatricians are of opinion that children less than 12 years should not be given NSAID unnecessarily. So if at all I use in children, I use only for 2-3 doses. Whenever there is muscle trauma like that, I use NSAID in children. I use only Nimesulide and only limited for a few days, less than 5 days per day. But you see here, in adults, fracture healing, this is a fracture healing. No NSAID, this much of fracture healing, Cyclooxygenase this much, Orthopaedic and ketorolac this much. So beware, ketorolac definitely inhibits fracture healing. So avoid this drug in first 1.5 months of the fracture. And something more about gabapentin. Gabapentin is more slowly and variably absorbed with peak plasma concentrations around 3 hours post-dose. Pregabalin is quickly absorbed with the maximal rate of absorption being 3 times that of gabapentin. It reaches peak blood concentration within an hour after injection. Pregabalin indicated for the same use as gabapentin plus the management of fibromyalgia. Pregabalin is especially different in fibromyalgia and neuropathic pains. So for us, pregabalin is definitely better than gabapentin. And toxicity of these drugs, the dose with greatest exposure in each study was 300 mg per day. There was no evidence of tolerance in 1 year study. Most frequent effects are dizziness, somnolence, headache, peripheral edema. Edema is common. Increased weight and mostly mild to moderate intensity. So if you watch, what you have to watch with the gabapentin, that is you have to watch with the edema. Then there are cyclooxygenase pathway to metabolize arachidonic acid derived from the lipid membranes. From lipid membrane, you go to arachidonic and they are metabolized here to produce various chemicals for use in body. The one is the cyclooxygenase 1. This is present in most cells, make physiologic eicosanoids. COX-2, insignificant in number, inflammatory, but in kidney and brain they are physiologic. So COX-2 inhibitor used to spare kidneys, but they were doing other actions. And COX-3 you must not have heard or you must have heard. COX-3 was told to be blocked by paracetamol. But it is not found in human yet. It is found in brain of the dogs, inhibited by paracetamol. What COX-3 does in humans is still not known to us. Bergstrom, Samuelson and Jain received Nobel Prize for their work on prostaglandins and nicotines in 1982. Arachidonic acid is a basic substance. ये वो खाना पीना है, गेहूं का आटा है, इसको लेके बाकी सब बॉडी की फिजियोलॉजी चलती है. This is basic substance from membrane phospholipids metabolized by enzyme cyclooxygenase into PGG2, PGS2, thromboxane, PGE2, PGD2, and PGI2. These are the metabolites. And cyclooxygenase path generate ring eicosanoids. Why eicosanoids? Because in Greek, icosa means 20. This is on the having 20 carbon atoms. So these are known as eicosanoids, and these are generated by cyclooxygenase. Lipooxygenase metabolize arachidonic leukotriene B2, C4, D, and E. This is a leukotriene manufacturing company, lipooxygenase. All lipooxygenase are blocked by steroid. So if you combine steroid with the NSAID, it is beneficial if you keep the dose low. As Dr. Arvind Mukherjee regime, he has got special doses which does not harm to the body and give you benefit of lipooxygenase inhibition. Few more lipooxygenase we know, that is diacerin. It is also lipooxygenase blocker, and one more drug is recently come. but there are very few drugs for lipoxygenase pathway. This is in lung, WBC, platelets are of SRS, slow release substance of the anaphylaxis. Lipoxygenase, this produces slow release substance of anaphylaxis. Selective COX-2 blockers are cardiotoxic owing to the uninhibited COX-1. So if we balance between COX-1 and COX-2, the side effects are lesser. Renal perfusion, mucosal integrity is a function of eicosanoids. Inhibited by NSAID led to the renal damage. How severe it is? Renal damage starts after third injection of diclofenac. So beware, injections are very toxic. Always limit NSAID injection to 1 to 2. And all NSAID injections, they are subcutaneous tissue toxic. And certain people, any extravasation to subcutaneous tissue lead to widespread gangrene and ischemia of the tissue. So whenever you choose giving injection of any NSAID like diclofenac, Nimesulide, or Cyclooxygenase, all these are available. Always choose intravenous route to be on safe side. Or rather, use very, very deep gluteal injection. Never allow them to spill back because they are very toxic drug to the skin and subcutaneous tissue, just like they are toxic to the renal mucosa. NSAIDs do not affect leukotrienes, rather increase it. Why do you increase them? Because the substrate is same and it is spared by blocking of COX-2s. So leukotrienes have more substrate of arachidonic acid and leukotriene production that increases. And sparing of more acids, steroids directly inhibit arachidonic acid release. Steroids, they inhibit arachidonic acid release from membranes by enhancing annexins and lipocortins. COX-2 inhibition is not direct, but through the opposing cytokine action. COX-2 drugs, they oppose the cytokine action. And PGE2 is anti-ADH and diuretic too. Prostaglandin E2, anti-ADH and diuretic. Hence, NSAID increase BP because they inhibit PGE2 and antagonize antihypertensive drugs. If you are using propranolol or any antihypertensive drug, you combine with NSAID, the effect of the antihypertensive is going to come down. This I have discussed with the many cardiologists. They are not aware of this action. When I have told them don't give Cyclooxygenase with the antihypertensive you give it, they are not aware and they are not ready to accept also. All NSAID are antibiotic, better than paracetamol. This is a PGE2 mediated pyrogen action. The action on fever, if you take Nimesulide, antipyretic action is 16 hours compared to the 2 hours for the paracetamol. Now we come to the aspirin and NSAIDs. When two rights make a wrong, NSAID and aspirin combination, the forward in this factor. This is one topic I have selected. This is a chart showing past complicated ulcers. 13.5% if you combine aspirin with the NSAID, multiple NSAIDs, that is 9, high dose NSAID 7, anticoagulant, interaction is 6.4, post uncomplicated ulcer 6.1, age more than 70 years, you have 5.56% more chances. SSRI, this is antidepressant, you have 3.6% chances, and steroid combination is 2.2%. This is odds ratio for the risk ulcer complication if you combine these drugs with NSAIDs. Then classification, 9 drugs, and there is another classification just to simplify. Salicylic acid, the commonly used drugs we have added here: aspirin, propionic acid, naproxen, ibuprofen, ketoprofen, oxaprofen, flurbiprofen. Anthracite acid is mefenamic acid. Aryl acetic acid derivative, diclofenac and aceclofenac. Oxychem, paroxychem and piroxychem. This is a short. This is given in KD Tripathi. Then pyrrole derivatives are ketorolac, indomethacin and nebimetone. Indole derivative is sulindex and indomethacin. And pyrazolone derivative is phenylbutadiene oxyphenol. NSAID selectivity. This is a very, very good chart I have found in KD Tripathi. The drugs which are more COX-1 selective, these are non-selectives, 5 to 50-fold COX-2 selective, and more than 50-fold COX-2 selective. And what does it give you? More COX-1, more gastric side effect, more COX-2, more cardiac side effects. So the numbers we have, COX-1 selective is ketorolac, fluriprophen, ketoprofen, indomethacin, aspirin, naproxen, tolmetin, paroxychem, and meclofenamide. So these are their parent companies, and these are drugs are more COX-2. Non-selected drugs are most safe. Ibuprofen, phenoprofen, sodium salicylate, and diflucinide. You can see here that one propionic acid is here, and another propionic acid, flurbiprofen, is in more COX-1 selective. And other drugs, flurbiprofen is also here, phenoprofen, in non-selective. Then more COX-2 selective is sulindac, diclofenac, celecoxib, meloxicam, and etodolac. But more than 50-fold, these are very toxic. That is etodolacoxib and lumaricoxib. These are most toxic. That's why I have told you that etodolacoxib is very toxic and still is available in the Indian markets. Then flupirtine. Flupirtine, I have told you this is a non-NSAID drug, but this is a very good drug for it doesn't cause nausea. It is a SNAPCO. What is SNAPCO? It is a membrane sensitizer. Flupirtine is an aminopyrine that functions centrally acting non-opioid analgesic. But in 2013, that is 7 years back, due to liver toxicity, the European Medicine Agency restricted use to acute pain for not more than 2 weeks. March 2018. Marketing authorization for flupirtine we have withdrawn. It's a selective, SNAPCO is selective neuronal potassium channel opener. Selective neuronal potassium channel opener. It also has NDMA receptor antagonist and GABA receptor modulatory properties. So this is flupirtine. It mediates through G protein, stabilized membrane, and NMDA and calcium decrease. So this is a very good drug, very safe drug, and it's safer in females. No nausea, no vertigo. Then come to the propionic acid derivatives, that is ibuprofen and others. This is the recent addition in propionic acid drug, that is nafopam. It is available in injection. It is available in tablets. And in injection, this is one of the safest NSAID I have got, and this is a good drug. Still I am using. This is a very, very good drug, very safe NSAID. It doesn't give blood pressure rise or any sort of problem immediately. So out of propionic acid, ibuprofen is also known as vitamin I. Many of you are not knowing that in list of vitamin, we have all the vitamins from A to Z. I have posted in one of my Facebook groups, all vitamins from vitamin A, M, B, all vitamins are there. And vitamin I is name given to the ibuprofen. Why? Previously, athletes, they used to engage in heavy works. So they could not do more work because of muscle strain. So when they were given a drug, ibuprofen initially in 1960s, so the pain was relieved and they used to work more. And then they named it as vitamin I. You take this and you work more. So whenever you have to have a running session of athletes or police or military recruitment, they are coming to you that give me some drugs, so they want to do more work, or you have to walk long for the Mansa Devi or something like that. You take one of the NSAIDs and you will not have leg ache or tiring. So propionic acid derivatives, non-selective COX inhibitors, high dose, they have to begin very high. Ibuprofen dose is 2400 milligram per day. They have low half-life, 1 to 2 hours, but they are better tolerated. Naproxone act on polymorph migration also, useful in gout and ankylosing spondylitis. Ketoprofen, lysosome stabilizer and LOX inhibitor. Indoprofen, almost same, like ibuprofen. Flurbiprofen, best for eye, and it is a gastrotoxic. So they have selected this drug for eye drop. If you go and find in market, you will find most eye drop for pain are flurbiprofen, and this is they act as antihistaminic also. Flurbiprofen is antihistaminic also. So all for eye allergies. Eye drop, you know, is aspirin eye drop is also available. I've seen. Flurbiprofen is the most popular eye drop because it is best for the eye and it is not to be used systemically. Phenoprofen, oxaprogen, nafusar. These are total numbers of the propionic acid we have. They all have almost similar properties, but Nefopom, it is a recent one and a very good and very safe and not expensive. Injection is costing only 30 rupees and tablet is costing 2-3 rupees only. Then another group is phenyl and heteroaryl acetic acid derivatives. These are tolmetin. What acid means? All acid drugs, they are rhinotoxics. Very simple rule. All acid drugs are rhinotoxic. There are 2 or 3 drugs, they are not acids. One is Novalgin, analgin. Another one is nabimetol. And third one is I have just told you, nafusar. Tolmetin, fever, pain and swelling. This selectivity. Ketorolac is more analgesic. So hence they choose this drug for the migraine pain. This is very, very good drug. Ketorolac injection aborts severe migraine immediately. Once a patient from here went to Australia for some business deal and he had some severe headache. They tried everything and he called me from there. They tell these doctors what injection to give. And I told them to find ketorolac and give, and he was relieved immediately. Diclofenac, toxic in 20%. This is one of the most toxic drugs we are using. Best effects because of best effects. And I tell you, in wholesale, you can get this tablet for 5 paisa each. So what this made a very attractive drug? Many Ayurvedic drugs, they mix 5 paisa diclofenac in their churn and marketed as a herbal analysis and selling it for 3 to 5 rupees per tablet. So this is the cheapest but most effective drug, but the most toxic also. Only safety with this, if you want to use with the misoprostol, not with PPI. What PPI does, they reduce gastric secretion and they mask the symptom of ulcer. They do not prevent ulcer. Remember, there is something very wrong. We are told, orthopedician, that I have seen the use of pantoprazole with every NSAID. This is the wrong thing. You should not use with pantoprazole because it is going to mask the ulcer symptoms only. It is not going to mask the ulcer. If at all you want to reduce the ulcer, you have to use misoprostol. Misoprostol is available in the market for the uterine uses. It is costing 15 rupees each tablet. And outside India, misoprostol diclofenac combination is available, but not in India. Aceclofenac is very, very safe for gastrotoxicity. It's a very good drug, less gastrotoxic. And I always prefer using aceclofenac than any other comparative drug. Bromfenac has not come in India, discontinued from hepatotoxicity. Then enolic acid and oxycames, they are antipyretic analgesics, NSAID. They work at very low dose. So what is in a low dose? Whenever you have a choice in antibiotic or NSAID, any drug, you should prefer a lower chemical load to the liver. If you are using 2400 milligrams of ibuprofen and 20 milligram of the paroxysm is doing same thing, this is low chemical load on the body and they are safer for the liver also. So always choose a lower dose. All the enolic acid oxygen, they are used in very, very low dose. And meloxicam is used only in 7.5 milligram. It's very low dose. I love this drug, but I know this is not freely available now. Oxycam has a half-life of 55 hours. Proteoglycan and collagenase inhibitor. Meloxicam lowest dose 7.5 grams selectivity to COX-2 is COX-2 to 1 is many times to COX is 1, half-life is 20 hours. Tanoxicam, this was a very good drug. I don't know why they have stopped it. 20 milligram dose and half-life was 72 hours. Its efficacy was good, and this was available in golden package, and it was a really golden drug. Pyrazolones. These drugs were banned in 1970 owing to agranulocytosis. But impression in young orthos that these drugs are still banned. No, they are not banned. They are banned for human use outside India in any other indication than ankylosing spondylitis or gout. Even in USA, you can use for two indications. But these are very popular drugs for the veterinary, especially horses. So for horses, this is very well used drug. But in human, you can use outside India only in two indications. And what is position in India? This is not banned in India. Only thing banned, we have given an RTI to know what combination is banned. It is banned in India or not. So I came to know that only combination with the paracetamol and phenylbutazone is banned. Alone phenylbutazone is very well available. Many companies manufacturing, and this drug is available with slight difficulty because of the bad impression we made. Phenylbutazone was originally made available for use in humans. It is in the treatment of rheumatoid arthritis and gout in 1949 when it was discovered that a solvent is a better medicine than the original current medicine. It is a DMARD. DMARD, you know, this is modifying anti-inflammatory drugs. Is in ankylosing spondylitis, this is not simple NSAID. This is the DMARD. It changes the picture of the phenylbutazone changes picture of the ankylosing spondylitis. I have seen many patients dying of ankylosing spondylitis, those who did not follow my advice. I discovered phenylbutazone is DMARD back in 1976. And I started using this drug since thereafter. And later I have found this is really a wonder drug because many people of ankylosing spondylitis, they have completed 40 years of the disease. And they are still well without side effect and no joint fusion, no death and no deformity in the spine or anywhere. In UK, this is used to treat ankylosing spondylitis. In India, its combination with the PCM is banned. Half-life is 4 to 8 hours. This is something wrong they have given. Half-life is very long. Other drugs are oxyphenbutazone, antipyrin, imidopyrin, and dipyron. This dipyron is still used in USA but not in India. Diaryl substituted parazolones. These are known as COXIPs. As I have told you, these are all sulfars. Very potent COX-2 inhibitors banned for cardiac Etorecoxib is the highest COX-2 selective. Celecoxib was the first one available. Then there came rofecoxib, then parecoxib, etorecoxib, and valdecoxib. Valdecoxib was safest of all. I have seen the birth and death of all these drugs. And I think most of people of my age, I have seen all these drugs. But you people might be seeing only etorecoxib. This is a very toxic drug. I have seen neurosurgeons, they are not knowing the dose. They are using it in 90 milligram TDS. The drug has to be given OD dose. Start with 60 milligram, give up to 90, and very obese person, you can use up to 120, OD only. because it gives severe edema, renal toxicity, and headache in overdose. Then other group is indole derivatives, indomethacin, ketorolac, and sulindac. Indomethacin, 1963, as a prototype benchmark COX and polymorphonucleosides inhibition potent drug. Mistaken as best drug by ignorant. Toxicity limits its use. Main use antipyretic in Hodgkin's disease and Barterer syndrome. What is Barterer? I'll just tell you. Tocolytic. Toco means childbearing. Tocolytic means childbearing. That's why the name tocopherol given to vitamin E, because it was thought to carry on pregnancy in rats. So that's why the name vitamin E is a tocopherol. So toco means pregnancy. Tocolytic in childbirth. PDA, patent ductus arteriosus, patents in ankylosing spondylitis more effective than aspirin. I have uploaded all these Greek and Latin words used in medicine to their English translation on website in 2000, 20 years back. And still that is available. If anyone wants to download that, he has to download Java in laptop and he can find all these words that toco or all these words like clavicle is key. So every such thing, every word meaning is available. If anyone wants, he can ask me. I'll give him the site address. Sulindac is a prodrug of sulfoxide, less toxic and renal sparing. It's a good drug, not available yet. Etodolac is a very good drug, still available. A uricosuric drug, COX-2 drug used in gouts. And what is Barterer syndrome? Patient have a mystery of maternal polyhydramnios and premature delivery. Polyuria, polydipsia, vomiting, constipation, salt craving, tendency for volume depletion, failure to thrive, and renal growth retardation. They can even this indomethacin. The Sulindac is available outside. This is just the label I have found out that is available in 150 milligram dose. Then other group is phenamides. Interesting drug. These are anthranilic acid derivatives of 1950s. Short-acting, half-life is 1 to 2 hours. Drugs, diarrhea is main side effect. Out of phenamides, you must be knowing mefenamic acid, Meftal, meclofenamide, and there is also flufenamic acid, which was available in India, but not no more. Side effect is diarrhea and hemolytic anemia. Salicylates, they are CNS stimulant drugs. So beware, any overdose of aspirin is going to give you salicylism. Salicylism means systemic alkalosis. Aspirin, low dose 1 to 2 gram daily, is uric acid excretion inhibitor. Antagonized uricosuric drugs 2 to 3 gram have no effect. 5 gram over is uricosuric. Stimulate steroid axis, fast absorbed from gastric mucosa. So if you take aspirin with the food, it is absorbed. That's why in headache, aspirin was very popular. Why? Whether you are full stomach or you are empty stomach, you dissolve one aspirin and take. It was very good drug for Anandkar, Avedan, Nirvedan, Saridon. Many patients used to aspirin. Nowadays they are using Premolazar. But aspirin was reviewed at that time of headache because it was very, very fast. Within 15 minutes, headache is gone. So in low dose aspirin, it blocks uric acid. In high dose, it is a uricosuric. So what we have to do, whenever I see a male having gout, I always inquire history of the cardiac diseases, because all of the cardiologists, they are mistakenly using low dose aspirin as a prophylaxis. Low dose aspirin only to be used if you have some angina or surgical element. Non-surgical prophylaxis, aspirin is not good, has proved in many studies, but cardiologists are very fond of giving, and out of their curiosity, we get patients of gout more than that what we expect. So any patient of high uric acid, always inquire that patient is not taking low dose aspirin. If at all he is taking, you can advise either to abstain it, change the drug, or use once a week very, very high dose like 350 or 700 milligram once weekly. So it will not inhibit uric acid excretion for gout cases. And the very, very good drug is benorelate. This benorelate is an aspirin paracetamol ester. It was misused as euphoric by manual laborers in England previously, and almost all of them have developed renal damage because they were taking these drugs unnecessarily for working more because of the euphoria caused by these drugs. So overwork they did and damaged their kidneys. So this was banned later on. It was given in powder to the British laborers. Another drug is salicylamide. I have used salicylamide because it came from leprechauns and blacks. It used to come in bottle like this. Diflucinil, more potent than aspirin. This is still not available. Only non-acidic NSAIDs are analgin and nabimetone. They are safe in kidney. Nabimetone, I think I have not used this long, it's not easily available. But Novalgin is a drug which was really a novel drug, different from any other drugs, metamizole. So this was given in combination with phenylbutyrol. At my times, Novalgin phenylbutyrol combination was the most popular over-the-counter drug, and it was very effective. Phenylbutyrol and Novalgin combination was very effective, and it was almost renal safe. But because of the later on, it was banned combination of the phenylbutyrol. This drug is vanished from the market as well. And mind it, that this drug was very, very powerful hypertensive. So anytime it was given IV, it's used to create shock sometimes. Metamizole or dipyrone is a painkiller, spasm reliever and fever reliever. So this was the main ingredient in Bralgan drug, antispasmodic surgeons use. It also has anti-inflammatory effects, and it was available over the counter in most countries before it was withdrawn due to severe adverse effect of the agranulocytosis. A safer, expensive drug. Last I used about 6-7 years back. This was 40 rupees each tablet. Indicated for the relief of signs and symptoms of rheumatoid arthritis and osteoarthritis. A novel opioid phosphor, no nausea. Nalbuphine hydrochloride injection. This drug I love, very, very effective and very good drug. Even in a very half or 1/3 or 1/4 dose, it works as a very good safe analysis. No toxicity. Still available. The alkalones is nabimetone, has been developed by BCAM. Non-acidic NSAID that is rapidly metabolized to liver. Being non-acidic, it is safe in gastric and kidney failure also. And the drug safe in gastric and gastritis and kidney failure is Nimesulide. Nimesulide, I tell you, is the safest cheap drug available in the market for us. There's some confusion. That is a toxic. It is not a liver toxic drug. Liver toxicity is seen in very, very high dose, not in routine dose we use. And if you stick to the 3 mg kg per dose, you will not have much problem. So this can be given in case of renal failures, because once you have a case of chronic kidney disease in your family, then you will learn that they often develop fever because of the cannula infection or something else, and you need something like paracetamol or these drugs. So nephrologists prefer paracetamol, but I don't prefer paracetamol. This is because that is more toxic than insulin. So in any case, if you have a family and developing pain and fevers because of the recurrent infection renal patient have, you can use nabimetone. This is much safer for reducing their fever and pain. But nabimetone can increase the risk of fatal heart attack or stroke. Do not use nabimetone just before heart or bypass surgery. Nabimetone may also cause stomach or intestinal bleeding, which can be fatal. Taking nabimetone during last 3 months of pregnancy may harm unborn baby. Tell your doctor if you are pregnant or plan to become pregnant. It could make your sunburn more easily. So these are 3 side effects. For that Nimesulide to be used only in very relative low indications. Then the most common drug we orthopedicians use is diclofenac. And there is a warning, we must all know. Maximal 3 injections are permitted by manufacturer. Although nowadays literature do not mention it, but initially when diclofenac came with the name of Moviron, they were giving a warning over their literature packed with each injection that do not use more than 2 injections at a time. Do not use more than 2 injections in a day, and do not use more than 3 injections all over. After that, you have to switch on to the oral drug. Why? I'll just teach you with next slides. I have seen people dying of renal failure post-operatively when operation was very, very good. But doctor has given diclofenac injection twice daily in 70-year female, and she died of renal failure 7 days. One of my classmates, topmost orthoplastic surgeon of Delhi, he had severe osteoarthritis pain and he could not think because of overwork. He took morning daily diclofenac injection and went to the work for 7 days. Nowadays, he is having chronic renal failure. Only 7 injections caused his kidney totally damaged. So this is a warning. You must learn. If at all you are using diclofenac injection, limit it to the 2 injections for safety. I have seen very, very severe hematemesis after single injection of diclofenac in old age person. So remember not to use injection in more than 70 years of age or less than 10 years. If you give diclofenac injection in 10-year child, he is going to develop hematuria almost certain. Children develop hematuria very easily if NSAID. That's why I have told you, avoid in 12 years or less. This medicine may raise the risk of heart and blood vessel problems like heart and strokes. These effects can be deadly. The risk may be greater if you have a heart disease or risk of a heart disease. However, it can also be raised if you do not have heart disease or risk for the heart disease. The risk can happen within the first week of using diclofenac injection and may be greater with the higher doses or long-term use. Do not use diclofenac injection right before after bypass or heart surgery. The medicine may raise chances of severe and sometimes deadly stomach or bowel problems like ulcer or bleeding. The risk is greater in older people and people who have a stomach or bowel ulcer or bleeding before. These problems may occur without warning signs. One secret I am telling you, if any patient coming to you, the doctor after taking your medicine, I have developed bleeding PR. If their rectal bleeding is there, it is almost certain that patient is having previously, unknowingly, he is having piles and not known to anyone. He has no symptom. The moment you give NSAID, they start having bleeding. So bleeding piles or bleeding PR after NSAID is one of the diagnoses of the piles I use. Then how should Danipar equate? This is right from the company's literature. All right. This is Troika company and Danapar injection. What warning they are giving? How should Danapar AQ injection 1 ml to be administered? And you know there are 2 injections. One is water soluble, available in 1 ml, and lipid soluble, it is available in 2 ml. That is painful. But aqueous or 1 ml injections are safer and better and less painful. So 1 ml injection should only be given by healthcare professional. It can be given deep into the muscles, intramuscularly, preferably into the buttock, under the skin, subcutaneous. This is wrong. Under the skin, not advised. Or directly into a vein. This is good. As a bolus, not as an infusion. So remember, diclofenac not to be given with IV drip. If it is IV, give right in the tube, not in the bottle. The dose should not exceed the prescribed quantity and injection should not be given for more than 2 days. So see, this literature is not available easily. They are clearly saying that not to be given for more than 2 days. So H in your brain, that diclofenac for all NSAID injection, only 2, not the third one. Question: can Danapar AQ injection 1 ml hurt your kidneys? Long-term use with a high dose of Danapar AQ injection 1 ml may cause renal problems such as protein or blood in urine or painful urination. I have one patient recently, and he was having dysuria for last 2 weeks after single injection of Danapar. I have given him misoprostol and he became all right. Patients who are at maximal risk of developing kidney problems include people who are dehydrated, have heart failure, impaired kidney function, hypertension, elderly, or who are on medicine which cause excess urination diuretics, or medicines which have significant impact of kidney function. Hence, for such patient, kidney function monitoring is recommended. Then you might know, might not know, there are 2 salts of diclofenac available in the market. One is potassium salt and one is sodium salt. So potassium salt is better. These 2 are talking. This is potassium one is laughing and sodium one is not laughing. So it says, I am more soluble in water and get absorbed quickly. So I start NSAID quicker than you. And this is crying that I have a delayed release. And you see the comparison between diclofenac potassium and sodium. The peak level of potassium is 1600 nanogram. That is about 1.6 milligram. And this is 1.2 milligram. And placebo should not have any blood level. So diclofenac sodium is inferior to the diclofenac potassium. And now you see, government has banned the veterinary use of diclofenac in 2006. Perhaps you are all aware, they have seen the death of the vultures because they are eating carcasses of the animals thrown in the open, and they died because of liver failure caused by injection of diclofenac given for the pain and fever to the animals. And they had high concentration of these drugs in the muscles. And vultures, when they ate it, a very small dose was toxic to the liver. People have did the postmortem and they have found the liver hemorrhage and very, very swollen liver of vulture seen. So ultimately they found the cause, that use of diclofenac in animals, and they are banned now. So it was found that once thriving vulture population in the country was near extinction after eating carcass of animals that were illegally treated with the human formulation of the drug. Toxic concentration to the kidney is 5.77 microgram per ml. And MIC means minimum inhibitory concentration is 2.2. So when you give tablet, you get this minimum inhibitory or effective concentration. But when you give injection, this is exceeded. IV exceed how much? I'll tell you. When you give IV injection, the blood level is nearing 7 microgram. It lasts for 15 minutes only. And after 15 minutes, it falls. So this is a very, very dangerous period, dangerous window. That if you give intravenous diclofenac, the renal damage starts for 15 minutes. But if you give another dose here, another dose here, another dose here, this toxic level is maintained for long. And the kidney damage ensues after 3 injections. And these are the blood levels. You can see this is for the after IM. IM is safer. It gives you peak only 2. And rectal, rectal gives slightly higher level, rectal, higher than intramuscular. So I think this should be better. This is safer because intramuscular injection is not good for the diclofenac. And rectal suppositories, they are almost better than intramuscular, but very, very high peak. That's why the pain relief is quicker. But the renal damage is also quicker. And you can see injection diclofenac oral reference, the Cmax is 6.031 rather than tablet is 1.23. If you apply diclofenac in the skin, blood levels do occur. So how much? They are very less. If you apply diclofenac topical, the blood levels are going to reach 20 nanomole per liter. And synovial fluid concentration 370 and synovial tissue is 400 times. So this crosses effective level. So if you apply over the joint, effective level is this and toxic level is not needed. Yes. Hello.
No
Hello?
problem. No problem. No problem. Somebody's mic was switched on and they accidentally submitted the sound.
Okay. So synovial level is 370 nanomole. That is the effective concentration. Serum tissue levels of diclofenac for half-life is 2 to 4 hours. Synovial half-life is 69 hours. So you can use this drug as joint pain reliever in BD dose. But if you are giving as analgesics, you will have to give very frequently, 2 to 4 hourly. So what we do, we add paracetamol with diclofenac to give analgesic effect in between. Anti-inflammatory effect lasts only 2 to 4 hours. But in synovium and joint fluid tissues, it lasts 6 to 9 hours. Injection 75 milligram, 2.5 to 8 micromole, 75 IV, 6.5 microgram, and 100 mg rectal is 3.5 microgram. And toxic concentration is 5.77. IC50 is 1 microgram. Matlab, whenever you are going to get 1 microgram level in tissue, this is effective concentration. Diclofenac oral, if you give 50 milligram, give you 1.25. That means equivalent to the minimum inhibitory effect. 100 SR gives 0.8 and 100 TR gives 1.8. So you see the difference. If you start giving diclofenac SR in beginning, you are not going to get minimum effect of 1 microgram. So remember, first give simple tablet for first 2-3 days, 50 milligram BD or 3 days. So to achieve this minimum effective levels, when the some plateau level achieved, then you can start SR preparation. If you give SR preparation right on day 1, the good effect is not seen. Topical serum is 20 nanomole, synovial fluid is 370, and synovial tissue is 410. This I have shown. Rationale for using aceclofenac in post-traumatic pain. I have told you the aceclofenac is much better and safer. So this I have derived from the aceclofenac literature itself. It is the preferential COX-2 enzyme inhibitor. Rapidly and completely absorbed foreign oral absorption. Peak concentration achieved rapidly is 1.25. That means that the effective concentration is achieved in 2 hours. Aceclofenac is well tolerated with a lower incidence of gastrointestinal adverse effect. I tell you myself, I don't tolerate diclofenac, but I tolerate aceclofenac well for 3-4 days without taking any other drug. So it is well tolerated with lower incidence of gastrointestinal effects, lead to reduced withdrawal rate and greater treatment compliance. Among the all analgesics, aceclofenac is the most commonly prescribed pain relieving drug for the management of upper limb fractures following trauma. So this is some chart. Ibuprofen is this much, and tramadol is this much, and tramadol is 13.5, and aceclofenac. This is the common usage that most volume is replaced by the aceclofenac nowadays. Then role of NSAID in trauma. Globally, NSAID are the most commonly prescribed analgesic medications for the pain. They reversibly inhibit cyclooxygenase enzyme COX-2, COX-1 and COX-2, which are involved in production of prostaglandins and trauma cells. Prostaglandin plays important role in inflammatory and nociceptive process. For efficacy, in a systemic review and meta-analysis, the use of NSAID after acute skeletal muscle injury was found to be associated with small to medium significant decrease in the markers of injury, presence of strength loss, soreness, increase in serum blood creatinine levels. So chemical tissue damage is definitely reduced with acute trauma. So I can say first 3 to 5 days, addition of NSAID in trauma is beneficial to the tissue damage. without causing significant renal and other damages. Then there is one very interesting phenomenon someone of you must have seen, because this is the rare thing. I have always seen such things, Nicolau syndrome, when injection were given by the Bengali or Chansi doctors or village doctors, Jholachap doctors. A great level of the, because of the seepage of the drug into the subretinal tissue, because they have habit of giving injection obliquely. But orthopedicians should always give injection vertically. Rather, all intramuscular injections should be given vertically. How I will tell you. So, giving subcutaneous injection of diclofenac, aceclofenac, or Nimesulide, it may damage in certain people vast areas. I have sometimes resected 8 inches circle of the skin and 1 to 2 kg mass of the gluteus muscle because of the severe ischemic gangrene occurred here. And this is the typical skin damage seen after injection. And this is not due to injection in the subretinal tissue alone. Because you have given with a thick needle intramuscular injection and you have not given air afterward, the medicine seeps back and creates this damage. This you must have seen, but this is Nicolau syndrome. Is a rare cutaneous drug reaction that occurs at the site of intramuscular drug injection. It can occur also with the other drugs also. First described in 1924 by Frudenthal in patients treated with the bismuth salt for the syphilis. Nicolau syndrome has been reported with the administration of other drugs like penicillins, local anesthetics, corticosteroids, and other non-steroidal anti-inflammatory drugs. But what I have seen, Nicolau syndrome always seen with diclofenac or aceclofenac, more commonly it is aceclofenac, and more commonly when quacks are giving this injection. So beware, if you are using NSAID injection, prefer IV. If not prefer IV, take a long needle and give deep intramuscular. So this is a Z-track method for the intramuscular injection. You pull the skin. So skin is stretched. Give a straight injection. When you release the pull, there is going to be zigzag formation of the tract. So it blocks the tract and do not allow to seep back the medicine into the subretinal tissue. This is a Z-track technique that is stretch it. You can either stretch like this or like this. Then give injection. Stretching also distributes pain receptors more distant. So whenever you prick with the skin, you prick less receptors and injection is less painful. So it gives you two things, stretching. One is a Z-track technique and less painful injection. Then other methods of giving injection is just and massaging the site is very popular, that they ask the patient to massage themselves and patient keep on massaging for 10 or 15 minutes. So this is a common thing, this is a wrong thing. And there is Z-track technique, this I have shown. And third technique is airlock technique. Airlock is a wonderful technique that I have read, gifted to me by a doctor who passed out in 1936, my friend's father. That clearly mentioned that do not give any intramuscular injection without injecting 1 ml of air afterwards. And I started following that, and I can boast that at my hospital, none has ever showed inflammation, abscess, swelling, or discomfort. Almost none. Until some new compounder has given without my guidance. Anyone who has used with this method, no complication of the injection procedure is seen. So Z-track technique is here. I have shown you by stretching skin, and airlock technique is this, that you use medication, then give an airlock. This air makes a bubble here, and this prevents medicine from escaping to the tract, and this tract is closed because it is not lined by the fat or grease or any oily substances present in the injection. So if oily substance is present, this will track back and it will stop the closure of this tract, and bacteria from here, they started entering here and give the infection. So infection is unlikely to occur when you close this tract immediately by injecting air. So this is known as airlock technique. This is very old technique. I think this technique was developed by Robert Jones in 1913 or 14. But because this is not popular and no one has ever read Pye's Surgical Handicraft in 1936. So because I have read and I came to know I am using this technique, and I assure you this is the best technique. You give air, air is totally safe. It is absorbed within half an hour. How much air is toxic in intravenous? 80 ml of air, if given intravenously, that can create bubbles in heart and cardiac tamponade by air. So remember, whenever you are giving intravenous drug, you can inject few bubbles safely. They are absorbed. It is only 80 ml of air which can lead to trouble, and doctors are unnecessary alarmed by a single small bubble injected in dip set, and we are worried that patient may develop some complication. No, they will not. In airlock technique, a small amount of air is withdrawn up in syringe along with the medication. The skin is stretched. That means that tract can also be combined with this. Flat between two fingers and held taut. Needle is plunged in right angle. So remember, never any other angle than this. And it is advisable in Pye's surgical that you go up to the periosteum, touch with the tip of the needle of the periosteum, and then withdraw for half centimeter or 1 centimeter. That is the safest side for the not damaging any structure. And same thing we recommend now in physiological portal injections also, that whenever a bone is there, you go up to the bone and inject just above periosteum. So inject above periosteum, it is safer. There are no structures, even though vessels and nerves are lying out there. But it is safest is go to near to the bone. But what is popular in cracks? That if the needle touches bone, the abscess will occur. This is the wrong thing. And plunge to the right angle, injection include medication followed by air, needle is withdrawn and taut skin is released. So this tract of the needle is stick again and closed. Then they advise large bubble, no, small bubble, okay. At the same time, it is believed that airlock technique, 0.3 ml of air used in injection reduces tissue trauma and reduces pain at the time of injection by preventing medication from the reaching to the subcutaneous tissue. He is advising 0.3, but I inject always half ml, 0.5 ml. Oily medicine tract, needle tract, and hinder closure of the tract. Leakage of the medicine is in subcutaneous tissue allowing entry of the bacteria from the skin. And you know, skin flora is resistant to the all antibiotic we use, because they know how to cope with you doctors. So the flora which is existing nowadays, it is resistant to the antibiotic. Anytime you invert the skin while suturing inside the wound, you are going to get a highly resistant infection. This is a very common mistake I have seen, that while suturing any post-operative wound, many surgeons give inversion of the skin, and the skin, when exposed to the deeper tissue by inversion of the dermis, it introduces bacteria inside which are resistant to the all known medicine you are using in your area. So to avoid this phenomena, oily medicine, you should always use air or airlock technique. This is once you tell the patient or some doctor, they sometimes wonder that you are fool, you are giving air. Air is toxic, but they have toxicity in their brain. Giving air has been proved safe in last 45 years I am using. These are my class notes. Oh, not class notes, sorry. 20 years after classes. It was in 1991 because the literature was available in a great detail. This much detail is not available on net, on website, and companies are no more giving that literature. So I thought I must tell you these interesting things that were available at that time. So this is a chart of diclofenac. This is the kinetics. You were given injection intravascular. This is the level. This is synovial level, which is much higher than the serum level. This is TR preparation, and this is SR preparation. They are two different preparations. TR preparation has got two capsules. One is immediate release and one is delayed release. So peak is higher. And you see here, MIC is 2.1. Analgesic is effect comes in 1 and anti-inflammatory effect comes in 2.1 micro. And analgesic effect, diclofenac 3, indomethacin 2.8, naproxen 15. It was very, very high dose. Phenylbutazone is 5, brufen is 30, and aspirin is 110. This is chart for ibuprofen levels. Mean serum levels following single dose of 600 mg and 400 mg ibuprofen. If you give 600 mg, this is 40 microgram peak level is achieved, and after 400 mg, 20, almost half. So you see difference, 600, 400 is not double. 400 mg gives only half the level, 600 mg gives better level. If you apply topical ibuprofen, no, this is not for, this is for the, these charts are for diclofenac actually. And this is the long-term. This is the for ibuprofen. If you keep on giving 12 hourly, the levels are maintained. Ibuprofen, the vitamin I, as I told you, this is the blood level. And the effect is lasting up to 12 hours. And these are different tissue levels. They are not available anywhere. Tissue levels in lungs, 3.5 hours, 12 hours, and 24 hours. This is for ibuprofen. This is, you see, this chart, you can note it down. This even company, good companies may not be having. That lung level at 3.5 hours is 12 microgram, 12 hours 6.6, 24 hours 2.1. So lung level is very high for ibuprofen. Bronchial is 2.5 and 0.18. Placenta 2.5, 6.2. So after 12 hours, placenta level is more. Ideally, such chart should be available for every drug we use. But sadly, companies don't want to give all these. So this is the rare chart I have, that pericardial levels, mucosal levels, synovial levels, periarthritic fluids, periprostatic fluid. Periprostatic fluid, if you give ibuprofen, periprostatic fluid is 6 and 26. This is very, very high level. Very high level periprostatic fluid in 24 hours. Then fat tissue, CSF levels, ascites fluid levels, prostate levels, urine and bile levels. So these levels are available. If you want to, you can use lower drugs, lower doses. If you are using prostaglandin, you can give a lower dose of ibuprofen because the concentration is already very high. This is piroxicam original monograph. Such a detail is not available. This is available only with diclofenac, Dolonex company, Pfizer. Other company cannot give that detail. They have used, how you see that drug testing is done. They have given 10 milligram dose first. This is the chart for 10 milligram. The blood level is 0.8 and lasting only for the 2.4 hours. Then they have given 15 milligram. So this is the blood level for 15 milligram. This is for 20 milligram, 40 milligram, 70 and 100 milligram. We have given maximum 40 to 28. So they have found average that giving 20 milligram gives safe and effectively. So they have chosen this doses. That's how a drug is chosen. So these are time 120 hours and the effect. This is, you see, the effect lasts for 120 hours after a single dose of paroxetine. And this is long-term effect, that too 8 weeks. This is the level. And the rheumatoid factor in joint. So if you can download this page, this is very important. And daily dosing 10, 20, and 30. The blood levels. And these are long-term levels, weeks. This is also for the long-term levels. And this is the chart for, yes, paroxetine. 40 milligram you have given one dose, 40 peak is reached, it comes down another dose and peak is maintained and higher. So 40 OD should be the dose for first 2 days. The plateau is obtained and then you can continue with the 20 milligram dose. Non-NSAID can be combined with NSAID for additive effect. That's why we have the preparations available, paracetamol with the NSAID. So they say paracetamol is synergistic till 1000 milligram only. So when you combine with 1 gram up to, it is synergistic. After increasing dose, there is no much effect. So this is the chart of paracetamol available with me. That if you give 500 milligram paracetamol, the blood level is peaking. This is 6 hours. So in 3 hours, the peak level of 10 microgram is achieved, and it comes to plateau of 6-7. And if you give tramadol, it is flat level. It is 37.36 after giving 50 milligram dose. Then NSAIDs comparative efficacy. Comparative with the carginine poedema of the rat and ulcerogenic ratio. For aspirin is 0.003 and 1 here. Mefenamic acid, same, almost. Indomethacin, 1,1. Ibuprofen, 0.1. So you see aspirin is more effective in carginine poedema, but less ulcerogenic ratio. And most ulcerogenic ratio is for mefenamic acid and naproxen. And this is poedema reduction by these drugs. Half-life of ibuprofen is 2 hours, diclofenac 2 to 4 hours, paroxetine 45 hours, naproxen 13 hours, and phenylbutadiene is 70 hours. So that I have told you in one chart, the half-life was given in 2 to 3 hours. No, wrong. Phenylbutadiene has very long half-life of 70 hours. Then phenoprofen is 2.2, indoprofen 3.3, tolmedin 53. Tolmedin is 0.8 to 11. Ibuprofen blood level is 40 microgram. 24 microgram daily gives 50% reduction of inflammation. So I have told you earlier, ibuprofen has got very, very high dose. Ibuprofen is good for the analgesic only. Anti-inflammatory dose for ibuprofen is very, very high. 2400 milligram is a very, very high dose. So ibuprofen is a poor drug if you are going to reduce inflammation. Aggregation of it reduces the aggregation due to deficiency of alpha A1. So now this chart, recently I have found out when the piroxicam was introduced, Pfizer company introduced in needle form. And Indian companies, they produce the cheap version, they produce cube form. All Indian companies apart from the Dolonex, they have form, and Dolonex alone has got needle form. And needle form is half as effective. The blood levels are higher and lower in the Dolonex, and superior viability 3.7 microgram per ml by local drugs, and Pfizer company drugs 1.9, almost half. So I have given a letter to Pfizer company that why you are still using this poor salt when better salt is available. I have their printed reply. They said on day 19, effect of both drugs are equal. So they say they are smug with their lower quality, and on 19 day onwards, you have same effect, but for first 19 days, you have half the effect of paroxetine. Crystalline structure makes difference in efficacy in oral brand is far inferior. Toluenex paroxetine is the inferior most paroxetine available in the market. Then come to my preferable drug, that is Nimesulide. Nimesulide is a sulfa. When I told to say lady doctor, she said Nimesulide is not sulfa. Then I said, see in the name, sulfa is in name itself. Nimesulide because of sulfa. This is sulfa drug. So any person who is having sulfa reaction, give him a test dose. I always try to give him test dose, that give half of 1 full tablet and let them wait for 1 hour. If there is no skin itching, then you can give safely Nimesulide. So what concentration we have? If you give 100 milligram tablet, after 3 hours, serum concentration is 5.8 and soluble concentration less, unlike diclofenac. Diclofenac is just reverse. Soluble concentration double. This is half the concentration in synovial tissue, and after 12 hours, the serum concentration is almost equal to the synovial and further less in synovial after 12 hours. So this is the way we can give the dosing at 12 hourly and enhance control of inflammation by reduce superoxide generation. This is the additional advantage which Nimesulide gives you over other NSAIDs. They scavenges hypochlorous acid. They inhibit platelet activation factor and they inhibit histamine also. And it reduces cartilage degradation. That's why if a patient is demanding analysis, you can use 2 drugs safely, Nimesulide and aceclofenac. They do not inhibit proteoglycans and they inhibit the proteases which damages cartilage tissue. So by giving these drugs, you actually help osteoarthritic patient. By giving other NSAID, you give more harm. Now about Nimesulide, it is a sulfonamide COX-2 drug, fever reduced for 16 hours compared to paracetamol 4 hours. Weak PG synthesis inhibitor. It's a weak PG synthesis inhibitor. Are you hearing me?
Yes, Dr. Diwaker, you are very clear. You are very clear. You are very clear. Your connection is a little slow, but your voice is clear.
Because it was showing that my connection is slow, that's why I asked.
Your voice is clear.
Because the translation was stopped actually, so I asked whether you hear me. And it is a weak PG synthesis inhibitor. Prostaglandin synthesis inhibition is less because it is a COX-2 blocker. TNF alpha inhibition. This is very, very important because TNF is the cause of damage in ankylosing and rheumatoid arthritis. So instead of giving TNF blocker, which is very, very costly and toxic, you can give Nimesulide simply. And one more thing about Nimesulide, which I have noted, in 2 of my family members, they have disseminated carcinomatosis. And the cancer pain was very severe. And Nimesulide was a drug which used to inhibit pain other than the very, very heavy dose of opioids. So in place of opioid in end-stage cancer, you can use Nimesulide in any dose. Forget about toxic side effects in heavy dose like 2-3 tablets in a single dose. So forget about renal damage because they are not going to survive that time. So in place of very, very toxic opioid or very costly opioids, you can use TNF alpha inhibition by Nimesulide alone. 99% absorption and half-life is 2 to 5 hours. Finnish committee told previously because this was a very cheap drug. Each tablet is costing to me is 11 to 16 paisa today. If I buy today, 16 paisa each tablet. And a cheap drug is 11 paisa. And very effective drug, very safe drug, safe in renal failure, safe in ulcers. So people, they are afraid. Other manufacturers, They blame this drug. They blame this drug having hepatotoxicity in children, although it is very, very rare. So they made even India to ban Nimesulide. But it was so much in use, it is such a safe drug. This was a cute and naive drug. He could not oppose the money poured in courts and the department of medicine department by other companies. They made it ban, but then Finnish committee, it told hepatic side effects equal to other NSAIDs as blame toxic. And hematuria is noted in children like other drugs. So after this, they again restarted manufacturing Nimesulide. This is freely available now. But it was a very good drug when introduced and falsely blamed by other companies as hepatotoxic, but it was not. And the Finland government has proved that it is as toxic as other NSAIDs, not more toxic. So this is chart from Nimesulide alone, same 3 to 4, and this is survival levels. And this is for the this is the Nimesulide level in gynecological tissue. It's quite good. Oral dose peak serum level 200 milligram is 8 microgram. 100 milligram 3.5 microgram. 50 milligram 1.7 microgram. 100 suppository 2.5. So suppository is good. Synovial level is 3 to 5. Gynecological level is 3 microgram per gram. So this drug is good for the gynecological tissue and the joint tissue. Another drug is flurbiprofen. This was also a very good drug, and these are charts which show flurbiprofen 100 milligram when given. This is the serum levels, and when you give SR preparation, this is serum level. And when you give synovial levels are peak level in youngs are less. This is peak level in youngs. This is peak level in adults, and this is synovial level. It is much less. But you see what I have written here, that for ear 3 microgram is sufficient. Dysmenorrhea 2 microgram is sufficient. I have written on the same level. So episiotomy very low dose. This is his indications. And this drug is no teratogenesis. Bronchospasm is present. Peptic ulcer rate is equivalent to aspirin. Steroid aspirin drug, and penetrate only in inflammation. Flurbiprofen has got some good thing. It penetrates only in inflammation. So it doesn't have much effect on kidney and other tissues. Urticaria, angioedema is present. Headache, dizziness, and insomnia and depression is seen because they are anxiety. Propranolol effect is reduced, but atenolol effect is not reduced. If you give flurbiprofen, anti-hypertensive effect of propranolol is reduced, but atenolol is not reduced. So by this information, we can have an edge over the cardiologists if we tell them they are not doing this. This flurbiprofen is a non-steroidal antidote drug. It is a potent inhibitor of prostaglandin biosynthesis. Flurbiprofen also causes marked inhibition of secondary phase of platelet aggregation induced by adenosine diphosphate and adrenaline, as well as collagen-induced aggregation in vitro and in vivo. So this drug can replace aspirin in cardiac diseases. Or if anyone is taking flurbiprofen, you should not operate immediately. Wait for 2-3 days. It is also known to inhibit leukocyte migration into the inflammatory site. Then very important thing, many arthroplasty surgeons, they have found in the literature that glucosamine is as good as placebo. Why? And some of surgeons like me, they swear that I can cure any arthritis, osteoarthritis with glucosamine. So where is the difference? This was found in my very, very old literature of 1990s. what the difference? Effective glucosamine level is 10 microgram in cellular tissue. Less than 10 microgram is not going to repair osteoarthritis. And the reason, they prepared 750 milligram tablet and we were giving BD, which is giving blood level of 2 microgram only, far less effective than the needed concentration. So if you use according to the company, you are not going to get any effect of glucosamine, and you advise the patient go for the arthroplasty. But when you use in single dose of 1500 milligram, you are going to get joint repair level, that is 10 microgram, and you are going to avoid arthroplasty altogether. And you will love this drug if you use in proper dose, proper salt, and proper company. Poor companies do not give 10. You see that margin efficacy window is very, very narrow. That the peak level only is the effective level. So if you use any poor brand or you give in device dose, you are going to blame glucosamine and you can label it as placebo. But if you use proper dose, proper brand, you use as a wonder drug than placebo. So this is ketorolac ED50 is 0.35, diclofenac 2.1, ibuprofen 17, and aspirin 9. I have shown you ibuprofen was giving me blood level of 40 microgram. And aspirin give very, very high level. Nimesulide is 120 times more potent than aspirin, weight to weight, 30 times more potent to flabrazone, and 15 times more potent to indomethacin. So now you can see indomethacin is 15 times poorer than nimesulide, and still people hail indomethacin as a good drug because of the such a great detail is not available to the common people. Luckily, I preserved that my old notes, although you can see the page they are noting, but I preserved and I have taken it now as a print. So I preserved this information and I thought I should dole it to all of you, so you should know what thing is not available anywhere nowadays. And you see, prostaglandin inhibition at therapeutic dosing, ketorolac is 100%, ibuprofen 20% only, and naproxen is 10% only. So I have told you that these drugs you use as analgesic only. But when anti-inflammatory, you can use ketorolac, but ketorolac is cardiotoxic. So do not use with the cardiotoxicity or do not use for long term. And this is the same chart I have made here, but I could not read what written here, so I did not write it here. This is the same chart given here. And this is the same chart I have given here. The risk of GI bleed appears to be highest with the ketorolac, and then in decreasing order, paroxetine, indomethacin, naproxen, ketoprofen, meloxicam, diclofenac, and ibuprofen. So high risk with ketorolac, then paroxetine, indomethacin. I have seen severe GI bleed in elderly with single dose of iron diclofenac. So much so that I had to go for the endoscopic treatment. Common adverse effect of NSAIDs is effect of gastric mucosa. Prostaglandin like PGE2 and PGI2 protect gastric mucosa by inhibiting gastric acid secretion, increasing mucus and increasing gastric blood flow. Loss of these action damages gastric mucosa, causing ulcers. Stomach mucosal layer, and this is stomach lumen PS2. SCO3 also is decreased by NSAIDs. NSAID may cause increased risk of serious cardiovascular thrombotic event, myocardial infarction, and stroke, which can be fatal. The risk may increase with the duration of use. Patient with cardiovascular disease or risk factor for the cardiovascular disease may be at great risk. Tolactin, tolmethylsodium sodium, is contraindicated for the treatment of perioperative pain in cardiac setting. Unwanted side effects of NSAIDs. NSAIDs, including, can lead to onset of new hypertension or worsening of pre-existing hypertension, either of which may contribute to the increased incidence of cardiovascular events. Patients taking thiazide or loop diuretic may have impaired response to those therapies when taking NSAIDs. NSAID is in tolactin. Here it was missing tolactin. Tolmectin should be used. This was I copied from tolmectin literature. That's why everywhere they are using tolmectin. Should be used with caution in patients with hypertension. Blood pressure should be monitored thoroughly during the initiation of NSAID treatment and throughout the course of therapy. This thing I have to teach to my local cardiologist. Congestive heart failure and edema. It's very, very common that patient coming to you with the edema. Now I will tell you 4 or 5 things. If any patient who is coming to you with the leg edema after your therapy is started, what should you suspect? First thing, it is a brand of the variety of the number 2, anti-diabetic drug. Pioglitazone commonly gives swelling. Antihypertensive drug, amlodipine is a common cause of swelling. And the swelling caused by the thyroid precipitation itself. If hypothyroid precipitates, there is swelling. If uric acid increase, there is swelling by your drug. And rarely, if painful edema is there, I have found chronic myeloid leukemia as a cause. If person is coming to you with painful ankle edema, always go for CBC test. So, congestive heart failure and edema, if patient has, he can precipitate congestive heart failure because of the overload of the fluids. And fluid retention and edema have been observed in some patients taking NSAIDs. Use with caution in patient fluid retention for the heart failure. Then drug interactions. This is also an important topic. We can get a printout of this and keep it on the table. ACE inhibitors, drug interaction with ACE inhibitors. Reports suggest that NSAID may diminish antihypertensive effect of ACE inhibitors. This interaction should be given consideration patient taking NSAID concomitantly with the ACE inhibitors. Aspirin, as with other NSAIDs, concomitant administration of tolmectin sodium and aspirin not generally recommended because of the potential of increased adverse effect. Diuretics, all NSAIDs are inhibitor of diuresis also. Clinical studies as well as post-marketing observation have shown that NSAID can reduce natriuretic effect of furosemide and thiazides in some patients. This response has been attributed to the inhibition of renal prostaglandin synthesis. During concomitant therapy with NSAIDs, the patient should be observed closely for signs of renal failure as well as to assure diuretic efficacy. How will you know that renal failure is occurring? Not only pedal edema. If eyelid edema is there, it is sign of renal damage or renal edema. Any person who is coming to you with eyelid edema, it is nothing but renal. If pedal, it can be renal or it can be anything else. Then lithium. NSAID have produced an elevation of plasma lithium levels and reduction in renal lithium clearance. Where do you give lithium? You give in bipolar disorders. Bipolar means maniac depression psychosis. And if you don't ask them about lithium, very lithium high level occurred, patient come to you in alkalosis and highly increased respiratory rate. The mean lithium concentration increases 15% and renal clearance decreased by 20%. These effects have been attributed to inhibition of renal prostaglandin synthesis by NSAIDs. Thus, when NSAID and lithium are administered concurrently, subject should be observed carefully for the signs of lithium toxicity or reduce the dose of lithium. Simple. Common side effects are in gastrointestinal, they are nausea 11%. You see, quite high. Actually, we don't observe because you are doing pantoprazole with dampered, so you don't see side effects. Nausea 11%, dyspepsia, gastrointestinal distress. You see, this is a very common side effect, distress. How does patient complain to you? They tell you, Doctor, my stomach is full of medicine. I have taken too much of medicine. My tummy is feeling full of the medicines. It is not full of the medicine. This is gastrointestinal distress. Abdominal pain, diarrhea, flatulence, vomiting, constipation, gastritis, and peptic ulcer. Another side effect of NSAID is dizziness. And for dizziness, what Indian people complain? They complain that your medicine is hot. Or they say, Doctor Sahab, aapki dawai garam hai. Garam means you understand. In their language, they are complaining of dizziness. And they are complaining of full tummy, that is gastrointestinal distress. 40% of the ulcer patient have prior history of peptic ulcer disease. And we are receiving concomitant anti-inflammatory drugs, including corticosteroids, which are known to produce peptic ulcer. So, any person who is already having gastric damage and taking steroid, and if you give an NSAID, next day he is going to come with a bleeding. Body as a whole, I told you many NSAID, they themselves cause headache. And you increase the dose for headache, the headache will increase proportionately. So you may surprise that why headache is not reducing and I am increasing the dose of analgesic drug. Because you withdraw the drug, headache will go. Same thing happens with the quinolones also. There is quinolone headache also. When initially quinolones were introduced, I met one of my friend at Agra. He was a neurosurgeon, and I have told him that, do you see that quinolone having headache? He said me, oh buddy, you are from a distant place, I'll disclose you. Quinolones are so common cause of headache that doctors, surgeon treating after post-surgical cases with quinolone, and patient is complaining headache, and they give NSAID and headache increase. So they wonder, they call me, they pay me fees, all right. So I have gathered, I have made a separate box for the keeping money collected by consultation of the quinolone headache only. And he did not disclose it to Agra surgeons, because if they know it, they will stop calling him. So when he collected 16,000 rupees in 1986, he bought a scooter out of that money, and he showed me that scooter. You see that Vespa scooter that I bought from alone quinolone headache consultations. So now think, whenever a headache is coming in your post-operative cases, it may not be spinal headache, it may be the headache given by your drugs. So gastrointestinal, elderly and RA patients are very sensitive. That I tell you, if any patient who is in an RA or he is elderly, he is very sensitive to the gastric side effects of NSAIDs. So I always reduce dose to 50% for all patients having age more than 75 years. As a rule, I give 50% dose of NSAID always. 40% of ulcer patients have priority, this I have told you. Body as a whole headache, yes, NSAID headache is common. Asthenia and chest pain is also there. Cardiovascular, elevated blood pressure and edema, I have told you already. CNS, dizziness, drowsiness, and depression. Depression, you know, because of the axillary effect. And dizziness, I have told you, when patients say medicine is hot. Metabolic and nutritional, weight gain and weight loss. Weight gain due to edema and weight loss due to appetite. Dermatologic is skin irritation, sunburn. Special senses, tinnitus and visual disturbances. Hematologic, small and transient decrease in hemoglobin, and hematocrit not associated with gastrointestinal bleeding have occurred. But without bleeding, you can see loss of decrease in hemoglobin. These are similar changes reported with other NSAID drugs. And urogenital, elevated blood urine natrium, urinary infections, and hematuria, all three infections can be seen because of the reduced immunity of the local tract. And one thing more I have found, every single tablet of aspirin give you gastric blood loss of 27 ml. That's why if you have iron deficiency anemia seen in female, it is dysmenorrhea. In male, it is either piles or NSAID. Long-term NSAID give you iron deficiency, may not be low hemoglobin, but iron deficiency, what it gives you? Loss of mathematical calculation, hair loss, and decreased IQ. These are the symptoms of low iron levels without giving you low hemoglobin. So any case of male person who is having loss of hair or anemia, always suspect you have to stop NSAID first if he is not having piles. Then in the series of common side effects, methotrexate. This is commonly we are using, so it is very much concern to us. NSAID have been reported competitively inhibit methotrexate accumulation in rabbit kidney slices. This may indicate that they could enhance toxicity of methotrexate. Caution should be used when NSAID are administered concomitantly with methotrexate. This I have to send to Dr. Arvind Mukherjee using too much of methotrexate. Then the warfarin sodium. The effect of warfarin and NSAID on GI bleeding is synergistic, such that users of both drugs together have a risk of severe bleeding higher than users of either drug alone. However, increased prothrombin time and bleeding have been reported in patients on concomitant NSAID and warfarin therapy. Therefore, caution should be exercised when administering NSAID to patients on anticoagulants. Then hypoglycemia. Hypoglycemia is always seen with all NSAID, and that's why in all my patients who come to me for some reason and having high blood sugar, I prefer them giving Disprin. It reduces at least 20% of the blood sugar level. In adult diabetic patient under treatment with either sulfonylurea or insulin, there is no change in clinical effects of either NSAID or hypoglycemia. But Disprin is the drug which gives hypoglycemia, or rather increases hypoglycemic effect on other drugs. So Disprin secretly I use to reduce the blood sugar level along with the other treatments. Average blood loss with every dose of aspirin is 26 ml. And iron deficiency anemia in males suspect NSAID as a cause. Then gastric mucosa, all NSAID produce gastric mucosa damage, ulceration and blood loss varying extent. That means every dose is giving you small damage always. But you see effect when there is a lot of damage. Due to inhibition of OX1-mediated synthesis of the gastroprotective PGE2 and PGI2. Also, back diffusion of hydrogen ion gastric mucus. This is causing back diffusion of hydrogen ion because of the acidic nature of the drug itself. I have told you previously that acidic drugs cause more damage because of the back diffusion of the hydrogen ions. And deficiency of prostaglandin reduce mucus and HCO secretion, promote mucosal ischemia. Enhance aggregate factors over defensive factors. Also, the paracetamol is free of gastrotoxicity. Selected COX-2 inhibitors and misoprostol. Well, these are all three can be used in case. Then SSRI, I have always told you interaction initially. SSRI, selective serotonin receptor inhibitor. And NSAID interaction kind of drives me crazy. It is one of those interactions where you don't really know how seriously you take it. SSRI have potential to impact platelet function. NSAID have potential to impact platelet function. So both the drugs platelet action is represented by increased risk of bleeding. So with SSRI, reduced effect of SSRI as well as the increased effect of bleeding is seen. So you have to see before giving NSAID that patient is old, young, cardiac, gastric, kidney or psychiatric. So all these drugs to be taken care. What should we take care? Whenever we are giving more than a week, then always consider these factors to be taken in consideration. If you are giving less than a week, many people tolerate it well if they are not old age. Pathogenesis. Aspirin and many NSAIDs are weak acids that remain in non-ionized lipophilic form. When found within the acid environment of stomach, under these conditions, NSAIDs migrate across lipid membrane of epithelial cells, leading to cell injury once trapped inside intracellularly ionized form. So ionized aspirin, aspirin, diclofenac inside the stomach cell, they create acid milieu. Whenever they go to acid milieu, they penetrate. Then comorbid condition aggravated by NSAIDs. 10 o'clock. It is 2 hours past. Oh, great. 1.5 hours. Peptic ulcer, hypertension. This is simple KDT. This is very good chart. Peptic ulcer, hypertension, congestive heart failure, renal insufficiency, and hemostatic disorders. And you can add SSRI also. Then drug interaction with NSAIDs, diuretics, reduced diuresis, beta blocker, reduced antihypertensive effect, ACE inhibitors, reduced antihypertensive effect, anticoagulants, increase bleeding, sulfonylurea, increase hypoglycemia. So you have seen that different books give different things. The chart previously I have showed that told you that there is no hypoglycemia. But this KDT is saying the hypoglycemia is there. And that I have observed also. Because I use NSAID as an antidiabetic drug also. And one thing more I told tell you. Pantoprazole, esomeprazole, omeprazole, all these are hypoglycemic drugs and are being used in high doses. So 40 milligram TDS pantoprazole is being used as hypoglycemic drug in diabetes. So you can, for diabetes, these drugs are additive hypoglycemia. If you use PPI, NSAID, and antidiabetic, they are all synergistic. Then alcohol, increased risk of GI bleeding. Cyclosporin, increased nephrotoxicity. Corticosteroid, increased GI bleeding. The reason you understand very well now. Then pharmacokinetic, the difference in kinetics, anticoagulants, metabolism inhibited. Coagulants, sulfonylurea, phenytoin, and valproates. Metabolism inhibited, higher blood levels. And decreased renal excretion of digoxin, lithium, amino oxide, and methotrexate. So if you combine with these, decreased renal excretion and higher level. These are NSAID common side effects given by KDT. Then use of NSAID in sports and trauma. This I have taken from the sports site. Effect of bone healing. During bone healing process, prostaglandin E2, which is activated by cyclooxygenase enzyme, plays a major role. That means you need prostaglandin E2 for fracture healing. And you should not unnecessarily inhibit it. Because healing ensues after 13-14 days. So you can use NSAID in, I have told you first 5 days you can use NSAID, they are good for the tissue prevention damage. But after that, bone healing is reduced. And in activation cascade of osteoblast and osteoclast, and potentially in differentiation process of lesion covered cell into osteoblast. So osteogenic potential of the bone is going to be reduced if you are giving unnecessary NSAID for the long term. And you are going to have delayed healing non-union. And you blame patient for that. But you should blame yourself that avoid NSAID. A negative effect of NSAID inhibiting COX-2 enzyme was observed in several animal studies by delayed and structurally immature and weaker bone healing under the treatment of ketorolac and others. It seems that very early use of NSAID might be the cause of this negative effect in fracture healing, especially if administered for more than 1 to 2 weeks. Application of paracetamol did not have negative influence on bone healing, neither low nor high concentration, supporting a direct effect of NSAID on early fracture healing rather than purely analgesic effect enabling too early weight gain. Some people may argue that because of the analgesic activity, patient early weight gain. No, it is you have been inhibiting osteoblast directly. Then the misuse of NSAID. NSAID are potent analgesic medications, but due to their anti-inflammatory property, their intake should be wisely indicated. Inhibiting early excessive inflammation without decreasing tissue healing potential. A decrease in protein synthesis and proliferation of satellite cell in muscular tissue, a decreased hyperemia in peritendinous tissue have been reported after the intake of NSAIDs. Whereas NSAID may be beneficial for first 2-3 days after structural muscle injuries in paratendinitis. Deleterious effect might be found in early and late administration for fracture healing and chronic tendinopathy treatment. One relevant thing I must inform you all that all antibiotics are anti-immunological. They are immunosuppressant. Immunosuppressant directly proportional to the dose in milligrams. So if you are giving a 5-gram dose of a drug, it is going to be very, very powerful immunomodulator. Or infection may be increased. Suppose if you are using a drug in 2-3 gram like ceftriaxone 3 times in a day, so it is going to inhibit your immunological potential, and it is going to invite the resistant infection to the ceftriaxone. So it is wise to use the antibiotic which is in milligram the lowest, the 100 milligram, 200 milligram, 400 milligram rather than grams. Number one. Number two, all antibiotics inhibit protein synthesis. They decrease protein synthesis of bacteria also, because protein inhibition is the basic function of the antibiotics. So they inhibit to the bacteria and human also. So whenever you are going to give any antibiotic, prefer lowest dose one. Only group of drugs which do not inhibit immunological function or which are not immunosuppressant are the group of macrolide, azithromycin, erythromycin, and all these related drugs. They do not inhibit your immunological functions. Rest other inhibit immunology proportionate to the dose in milligram or grams they are given. And same thing happens with these NSAID also. If you use pyroxicam, it will be less inhibited to the osteoblast than the 2400 milligram of the ibuprofen. So thank you so much for listening for 2 hours. You see, this is a bouquet. This my granddaughter has prepared herself. She is very fond of this, and she put it in a jar and sent me a photograph. Dadaji, how does it look like? So this I have shown you. Keep a bouquet on your table. It keeps you fresh. Thank you so much for listening. If any question is there, I can give you 15 minutes more time before I go for my breakfast. So finish here.
Excellent talk, Dr. Diwaker. Despite your net being a little unstable, the talk was beautiful. Now, a lot of questions have come. You will need about 5 minutes to read the chat
Yes, yes.
and see the questions.
I can give half an hour time.
No, so what we'll do is I'm taking 5 minutes to give them a trailer of next week's talk, by which time you have to go through the chats, read all the questions, and then you can answer. You've got very good questions there, and we can answer them after 5 minutes. So in this 5 minutes, you just have a glass of water, get yourself fresh, and then look at the chats to see the questions. Okay. In the meanwhile, let me share my screen. Our talk, our class has gone very good so far. And here we are going to 1 minute. Here. Next week will be the last class of our session. And in this, we shall be able to give you a what do you call glimpse of there we are, of what I'm going to speak next week. Okay, so hopefully we will be speaking on a topic which is unlearning to learn, or the genesis of biological methods. So 5-minute quick synopsis. It is not where you are, but what you are that matters. The who and why of this talk, and my journey of 40 years, and how I moved away from commercial and operative orthopedics to more rational and biological orthopedics. In these talks, I would share a few of those lessons which I believe have made me a better orthopedic surgeon. My life as an orthopedic surgeon went through 3 phases: as a surgeon, as a prisoner, as a teacher. And each phase taught me invaluable lessons. From 1980 to 2020 years, I was a surgeon, a prolific surgeon, an AO man, and fixed every fracture. In this phase, I learned that surgical treatment produces superior results in non-operative management, and perfection of X-rays is directly proportional to the quality of results. In this phase, I learned that a good orthopedic surgeon is the one who operates on a large number of cases, and that arthroplasty is the ultimate achievement for an orthopedic surgeon. In this phase, I learned that AO is the best thing that has happened to fracture management, and I was taught that you learn the best of orthopedics by fellowships in high-tech, higher specialty centers. In this phase, I learned that more sophisticated your diagnostic tools, CT, MRI, etc., more accurate is your diagnosis. And then came the 13 dark years in my life where I was a convict prisoner, no facilities in the prison, had to treat everything conservatively. And here the lessons I learned were quite different. And I realized that many of my previous learnings were absolutely wrong. Surgical treatment of fracture produces superior results in non-operative management. This is wrong. Perfection of X-ray is directly proportional to the quality of results. No. I have seen ghastly looking X-rays giving excellent function, like beautiful X-rays with metal and pouring pus and a bedridden patient. A good orthopedic surgeon who operates a large number of cases. And arthroplasty being the achievement of an orthopedic surgeon, again or wrong, a good orthopedic surgeon is the one who knows when not to operate, and a good orthoplasty surgeon should know it more than any other orthopedic surgeon. AO is decidedly not the best thing that has happened to fracture management. Many may disagree that it is not the worst thing either, but it is just a thing which has to be taken judiciously. And these so-called sophisticated investigations have very limited use for your day-to-day practice, reserved exclusively for specific patients. These and other lessons which I have been discussing or teaching for the last 5 years shall be discussed in detail in the next talk. So I can stop my share. I can get back to Dr. Diwaker. Dr. Diwaker. Yes. Have you read the questions? You have to unmute. You have to unmute.
Akash, thank you very much, dear. You did a fantastic job.
Thank you, Dr. Shah. Dr.
Yeah.
Diwaker, unmute and talk. Answer the questions.
Yes.
And you are all invited
Because
for today's lecture also, which will be 1 hour or 50 minutes. And this will be the preliminary thing I showed you today, will be continued towards the end of next Sunday morning, 7:30 a.m. lecture. Dr. Diwaker, the first question that was asked was...
I'm reading question and asking one by one.
Yes, okay.
So,
First question was, indomethacin is considered to be a standard drug to avoid joint stiffness post-immobilization. Should its widespread use be discontinued for that?
okay, you read questions and I will answer.
Yes.
Now, what is the first question?
Indomethacin is considered to be a standard drug to avoid joint stiffness post-immobilization. Should its widespread use be discontinued for that?
Yes, indomethacin should be used only for the fever, not for the inflammation.
Okay. Next question.
It should be used for only for the recalcitrant or resistant fever like Hodgkin's disease. It should not be used as NSAID. It is an unsafe drug.
Okay.
Next question.
What is your opinion on the use of dermal patches?
Dermal patches are very good because they give absorption through the skin, and this is fashionable and patient love because we stick the dermal patches right over the painful area, so they are very happy. Just like cardiac dermal patches, they tell them to apply over the heart, so he's safe. He feels, although it can be applied anywhere, but he apply on the heart, so he feels, oh, it is going to work over my heart. Same thing, the patches, although are 50 rupees or so costing, but they give more satisfaction and placebo effect as well. Otherwise, they are equivalent and they bypass oral routes, so less gastric irritation, not completely eliminated, but they give very less gastric irritation. They are rather safer and they are rather more appealing and more active, and they are as effective.
Side effects
I
same?
found them good.
Side effects are the
Side
same?
effects are gastric side effects are less, otherwise same.
Okay.
Because the blood levels are same. Blood levels are same, so side effects are equal, except gastric levels are lesser because you bypass the oral route.
But how it is maintained the 24 hours? Means usually whatever drug we give, the first absorption is very fast.
It is behaving like oral single dose.
Huh?
It is behaving like oral single dose.
Okay. It's like SR, sustain release.
They are not SR. They are absorbed and blood level, peak level RD, then blood level is maintained for long. Effect is just like giving oral tablet.
Okay.
No,
Except it is bypassing oral route.
okay,
Yes,
but it is for 24 hours, right? That is for 24 hours.
No, it is according to a drug. If it is, then it is for 12 hours only.
Pardon, sorry, I could not understand.
It is equivalent to the oral tablet you have.
So every 8 hourly?
It is equivalent to the oral tablet.
So you have to
But
change
low
every
blood
8
levels
hourly?
persist for 24 hours.
Huh.
No. Change at the will. I never change the hourly. I tell them whenever you again have pain, you use it. Use at will. SOS.
Okay. Use at will.
Don't
Okay.
use. I don't use this like drug, oral tablet. I give it on the patch and tell them whenever you have pain, you take it out and apply.
And like do you prefer bupivacaine patch or ketorolac patch is better than the diclofenac?
They are all same. Just like the selection is like that. If you are using ketorolac, don't use perioperatively or don't use in cardiac disease. Indications are same.
Okay.
Except it is a more appealing way of giving less gastric toxic doses.
Okay.
You can use rectal also. They are equally good and more effective.
Okay.
related to this, why subcutaneous diclofenac has adverse effects while local application on the skin like skin patch and ointment do not?
Yes, this is a good question. Because Nicoll syndrome, it is seen not in every subject. All right. And the topical levels, tissue level I have told you was 370 nanomole per liter. All right. You have applied ointment, 370 nanomole have been percolated inside tissue. But when actual drug you give, just like I tell you, if you apply ointment, betadine, it is 2% or 1% or any antibiotic ointment. But when you apply the powder, the concentration is in grams. So it's a very high dose, it gives you tissue damage as well. So I don't prefer a sprinkling antibiotic powder over the bone. I dislike it. The concentration is high beyond toleration of the tissues. So the ointment have been prepared specifically with the vehicles not to exceed damaging tissue concentrations. All right. The companies have prepared non-toxic levels only. Understand? If you apply 50% diclofenac ointment, you are going to get, and that is 100% diclofenac, which is seeping. The seeping.
But how much it penetrates? How much it penetrates? And how the usually we know that
phone, just let me turn the phone.
Let him attend the phone. I'll answer other questions. Next question was, Dr. Diwaker, which glucosamine brand do you use? And what is the dose? The dose is 1,500 milligrams, single dose in the morning on empty stomach. And Dr. Diwakar's favorite brand of glucosamine is Tendokel. And he has been using...
Not Tendokel. I use only Lubrigiant Plus.
Okay, you type it and send it to us eventually.
Yes,
Now, the delay in fracture healing due to NSAIDs has already been answered. And for this, since we have invented DSCB, the use of analgesia post-fracture and post-surgery has come down very dramatically. I suggest you all to read the books and see the lectures on sodium channel blocks. How much aspirin for 27 ml blood loss? 1 gram of aspirin oral causes about 30 ml of blood loss in the form of occult melena, which you can find if the next day's stool is examined. So 1 gram of aspirin on empty stomach is a bad dose. Next question was, should we prepare opioids for the pain management in chronic ligament injuries or fracture healing, as even DSCB cannot use for every condition yet? Now, this question, I think Diwaker.
I'm back now.
Question was,
Because
should we
in
prefer?
my neighborhood, actually 2 patients of corona has occurred. You see, this is the brand I use.
Okay.
This is the best brand in the world over, not only in India.
Which company?
Wellness.
Wellness.
This is
Okay. What is the
called
name?
Wellness.
What is the name?
Wellness. The name is lubricant plus.
Okay.
There are many variety available, 500 milligram, 750 milligram, even 1500 is available. But all these are red marks, but 1500 milligram is not red mark. So this is the best quality. I use 2 tablets at single dose.
So 2 tablets at single dose? So 300?
Yes.
3000 milligram?
No. You have to give only 1500.
Okay.
750 into 2. Okay, next question was.
This is the best quality. And you see, I am buying in bulk. Recently, I have bought these tablets worth 50,000 rupees.
Okay.
So this costed me half the cost of the market. It is in the 6-7 rupees. This costed me only 3 rupees. In bulk.
Okay, next question was, should we prefer opioids or what analgesic for pain management in chronic ligament injuries or fracture healing, as DSCB cannot be used for any condition, every condition yet, and we have known that NSAIDs delay fracture healing.
I have already told, opioids should be used where inflammation is not a criteria. So you can use opioid, but they are nauseating, they are intoxicating, they are habituating. So you can select the safer opioids like codeine, paracetamol. Codeine is very, very popular in USA. Codeine, but codeine is constipating. So you use
Sir, there were so many cases in paracetamol codeine, now in USA.
I didn't hear you. Tell me, inform me.
Yeah, paracetamol codeine, there are big cases in USA. Because they made people addicted to it.
Addicts. Yes, there are class action lawsuits.
Yeah.
So addiction is
pharmaceutical giants.
Addiction is very only therapy is being addiction of IAOS is there.
For addiction, yes. Now, just last 2 more questions.
Is opium is good? Is opium is good?
Opium is not good. It is only good for the cardiac cases because of the severe side effects. So for orthopedic cases, we can use opium, just like I have told you, for the diagnosing also, it is a somatic pain or not, or for very severe pain, once in a while, you can use opium and pethidine both.
Okay,
last. You know how much it is there? If you order any opioid for 5 rupees, it will cost you 25 rupees ultimately after taxes.
Right.
The next was,
once it
routinely use PPI along with NSAID.
Again, please.
Please repeat the question.
We routinely use PPI along with NSAID.
No, never. PPI are one of the most toxic drugs. They are cardiotoxic. Common cause of heart failure is long-term use of PPI, particularly pantoprazole, for more than 1 year. If you are using PPI for more than 1 year, this is the commonest cause of heart failure and death. This I have seen 5 of my relatives. They died of heart failure caused by PPI. It causes magnesium deficiency, which is again harmful in orthopedics. So PPI are very dangerous. PPI NSAID is more dangerous. So it should not be combined. If any side effect is coming, you should reduce the side effect rather than masking it.
So what is your preference? So what will be your preference if you have to use?
You use a safe drug, which is just like you can. My friend Dr. Bhagia was there, an orthopedician. He is in Delhi nowadays. What he used to do in 1980s, he used to give them 5 NSAIDs that take one by one each day, which is the most effective and least toxic that you can continue for long. This is a good principle.
But toxicity, that is what we know. How the patient is going to realize?
We tell them that you have gastritis, you have swelling, you have chakkar, you have vertigo. So we give them information that take these 5 for only those cases we are going to give long term. You can use this, or you can tell them if any of the side effects come, you come and
So
get
5 NSAIDs you are giving. 5 different NSAIDs you give.
What he means was,
He was giving
Tuesday night diclofenac,
all.
Wednesday paracetamol, Thursday this like that.
Yeah, I understand.
On the 5th day, you are going to choose yourself which is the most convenient for you.
We keep on changing.
Based on the side effects the doctor has described to you, which is a more intensive and time consuming, and I think in these days not very practical methodology. We are running really short of time because we've got last 3 hours. So what we'll do, last question, safest NSAID in pregnancy.
Safest NSAID in pregnancy, remember, because PDA closure occurs in last 2 weeks. So pregnancy 3rd week, avoid all NSAID. Pregnancy 1st week, avoid any medicine. So you can use any NSAID during 2nd trimester. It's safe. But in 3rd trimester, do not use. Otherwise, you will have open PDA, patent ductus arteriosus. And these indomethacin particularly is being used for preventing closure wherever there is overriding of aorta or Fallot's cytology, where if child has closed PDA, he will die. So PDA has to be kept open before surgery. So people give NSAID, preferably indomethacin, so that PDA is not closed. So it is unsafe in normal people, understand? So the drug should not be given last month at least. This is my advice, that do not, otherwise you might not be knowing, but Dr. Prakash might be knowing because sister is gynecologist, that for a healthy generation of lung, low dose aspirin and low dose steroid are commonly used right since 1st trimester. So NSAIDs are not unsafe, but as like any other drug, you select pregnancy category. Pregnancy category 1, 2, 3 can be selected very easily. It can be given, but in last trimester, particularly last month, I advise you not to give NSAID without consultation of the pediatrician neonatologist.
Thank you all very much for a wonderful day. This is one of the longest sessions. And we are all again invited next Sunday morning, 7:30 for the last lesson of this course. IAOS has conducted 5 courses of interest to orthopedic surgeons.
Dr. Prakash, can we see it is there a recording available or is it on YouTube? The previous one?
Those are all paid courses.
Okay.
With certificate at the end of 3 or 4 months.
Okay.
Those courses are for Elizarov course is one. One is a course in hip arthroplasty. Third one is this biological course, which is non-operative orthopedic management. There's one course on pain portals, distal sodium channel blocks, and one course conducted by our Italian friend, Dr. Mario Tangari, on MIROS, M-I-R-O-S, which is a revolutionary new system combining external...
That you saw yesterday.
Yes. So these are the 5 lectures, 5 courses, and a new batch starts after next Sunday. So anybody who wants to join the next sessions of classes are welcome. And on the groups, I'll post the first and last lessons of all these courses to give you a general outline to see if it suits you or should you join the course. And the consequent courses in the coming weeks are flexible courses, meaning you don't have to be fixed at a specific time, leaving all other job. Every week you will get the lessons in PDF files. You will get the lectures of the PowerPoint in the form of a PDF file, and you will get a secure video link of the lecture. Every 4 weeks, you get a one-to-one Zoom with the faculty for half an hour where you ask all your doubts. And these courses last for between 3 to 5 months, depending on the subject. So I hope we are able to learn and share and learn more by teaching. Thank you all for your wonderful presence. Thank you and see you on next Sunday. Have a nice Sunday. Bye.